we don't just administer drugs. We make decisions that defines the outcome. So the decisions often made in few seconds and often under pressure and with no room for error. So be it like unanticipated difficult airway or choosing between conflicting international guidelines or deciding how much investigation is truly enough. So there are no textbook questions. So these are actual life challenges which we face daily, and that's what exactly today's webinar is about. So there are real cases, real dilemmas, and real decision making. So we are today privileged to have the stalwarts in the field, Dr. Sheila Maitra and Dr. Shilpa Tiwaskar and myself. Uh, I'm sure their experience in the field and the insights will help us enrich our knowledge and sharpen our critical judgment. I'm deeply honored to honored that Sam's office bearers presence, and thank you for joining and supporting us. I would like to appreciate moderators um, and thank them for steering this academic webinar, and most importantly, all the participants. Your enthusiastic participation and commitment to learning and evolving is what makes our faculty strong. So let us begin with this highly enriching and thought-provoking webinar. Once again, I welcome you all and thank you. Over to you, Bhavish.
Um, Yatin, Sheila is
Yeah,
starting next. First, Shilpa is starting.
yeah, I've told her. So, Manisha,
Hello.
yeah,
Yes,
you
sir.
can use the speaker.
Yes, sir. I'll be in. Okay. So I take great pleasure to introduce our Dr. Shilpa Tiwaskar, who is a senior consultant at Vedanta Hospital, Bhakti Vedanta Hospital and Research Institute. She also serves as the SAMS news editor for 2025 to 27. She's been honored with President Appreciation Award as well as Proficiency Award in 2023 and 2024. Beyond her impressive academic achievement, she is a humble, compassionate human, which I've recently met her on this weekend, and truly fortunate to meet her over the weekend. And now I would like to introduce her to the Thane ISA webinar and take up the topic.
Thank you for the kind introduction. Hope I'm audible.
Yes, ma'am.
Thank you, ISA Thane, and thank you, Dr. Yatin Khernar, sir, for the invitation and this honor. Thank you, Dr. Avinash Bhosle, sir, President SAMS, for joining. Can I start sharing my screen? And thank you all senior members of ISA Thane. Yes, so we directly go to today's webinar, and the topic given to me by Dr. Yatin is airway wars. What should you follow? I will try to be more practical. Theory will be, of course, there everywhere. So what points we need to take from theory? Let's see. IDA guidelines, DAS guidelines, and ASA guidelines. IDA guidelines, we all know they are All India Airway Guidelines, All India Difficult Airway Association Guidelines. First, they came in 2016, then 2025. The Difficult Airway Society Guidelines of UK and Europe, first in 2004, then 16, then 25. And American Society of Anesthesiologists Guidelines in 13 and 22. Now, what these guidelines tell us? I have a case scenario. 1 minute, I have to just... Okay, fine. I have a case scenario. A female 48-year-old with BMI 45, 148 centimeter, 98.6 kg was posted for abdominal hysterectomy. 98 kg is nowadays a little more common. And she was in neighboring OT, and a second anesthesiologist was called when that first anesthesiologist encountered some difficult airway. Second anesthesiologist was called when 8 minutes had passed post neuromuscular blocking agent and saturation was 92%. The mass ventilation had become inadequate, so naturally there was difficult intubation. Now, the first anesthetist who had started the case was also a senior experienced one, and the second anesthesiologist was called when there was inadequacy of mass ventilation. So we don't know how many attempts of intubation and with what they were caused. When the another senior second anesthesiologist reached, he saw that the ramp was disrupted and mass ventilation was inadequate. Now, Dr. Manisha Singh, I would like to see if any audiences are answering in the chat box.
Yes,
My,
ma'am. I'll keep
yeah.
an eye.
So the first question is, when should you call for help? After the failed first laryngoscopy and intubation, or after the operator has tried 3 attempts at intubation with different device and technique? Normally, I want practical answer, not the theory. Normally, when do we call for intubation? And has anyone answered in the chat box?
Yes, we've got an answer B. Yeah.
Yeah.
And one is after the first attempt, multiple
Mhm.
answers.
Yes, yes.
Multiple
Yeah,
answers.
so-
Mostly
yeah.
people are choosing A and B.
Yeah. So basically, it's like previously, 10 years back, even I used to do at B. After I changed my, that time video laryngoscope was new. So after laryngoscopy, then using McCoy, using Buji, using Burp. But now, at my first failed laryngoscopy and intubation, I call for help.
Yes.
Though that person who comes for help may just stand
Hmm.
while I'm changing the instrument, while I'm changing to video laryngoscope, while I'm giving different position, that person can just come and stand. But it is advised to call at the first failed laryngoscopy and intubation.
Yes.
And I'm sure if Sheila would have been here, she would have asked me to change that word at the first airway, whatever you are securing. So as first failed airway attempt, you should call for help. So here that second anesthesiologist was called for help at 8 minutes. So maybe 3 minutes after neuromuscular blocking agent laryngoscopy was tried. Okay. Now, when should video laryngoscopy and Buji be used in obese patient? After failed first laryngoscopy or for first attempt itself?
Many answers are B, madam.
Yes. So till 3-4 years back, I was like, no, I'm used to laryngoscopy. I want to see the view entirely, but I had a big learning curve for a video laryngoscope. But after that curve is over, I know that for a obese
For
patient, I have to use, I have
Yes,
to
yes.
use a video laryngoscope and Buji first. During attempts at intubation, how many of us will give nasal oxygen with cannula should be there? ऐसा करते हैं क्या कि मास वेंटिलेशन किया, फिर बाजू में nasal oxygen ready रखा, change to open circuit, वो लगाओ and then intubation करो. So anyone does that?
Yes, we do that. Or we have the separate auxiliary if available, we can use that. Nasal prong attached to the auxiliary. O2
Yes. So
connection.
are we doing that? Are any answers there in the chat box?
Yes, there are multiple yes answers, madam.
Good. At present, I'm doing only when I'm loading the drugs. I'm attaching nasal prongs, and that is what. And once I am doing mass ventilation, after that, I'm doing laryngoscopy. But yes, it is 100% advised that whatever you have used preoperatively, just make a habit to put the nasal prongs before you attempt first laryngoscopy. How much should be the nasal oxygen? 10 liters or 15 liters? Not 5 liters. So how much it should be?
Waiting for answers. 15? 15 liters?
Yes, it should be 15 liters. And when should decision of mobilizing EFONA, that is emergency front of neck access, which the DAS guidelines use, our
Yes.
IDA guidelines use surgical cricothyrotomy. or emergency cricothyroidotomy. So when it should be done, when the decision should be there, had failed first attempt to secure the airway or after complete ventilation failure? Any answers?
After complete ventilation failures.
Yeah. So here lies the difference between the two guidelines. What IDA guidelines say, of course, it should be ready, but we should think of it after complete ventilation failure. But if you see the DAS guidelines 2025, at very first attempt of failed intubation, they say mobilize the ePhona. That means your brain should be accustomed that anytime we can go on a decline pathway and we might require ePhona. So they are saying at failed first attempt to
secure it.
Yes, please think of ePhona. Then for a physiological difficult now, see this anesthesiologist, what she did, she sent call for help at 8th minute. Then she had a physiological difficult airway. Whether the ramp was given properly or not, and then within attempts it had disrupted, we don't know. Plus, what she had not done. If the mass ventilation is difficult, what is the most important thing to do in a physiological difficult airway? Either use a SGA or try to change patient position or try repeat attempt by VL scope. What would members suggest?
Use SGA.
Yes. So once you see the saturation coming down, and so it should be, see, the guidelines say 2 attempts, 3 attempts, which I'll come to that later. But what should come into your mind? Now my saturation is falling. I have to go to the next step. I'm not able to maintain oxygen saturation with mass ventilation or with intubation. So at least put an SGA. So now this actually Dr. Nilima Kelkar had asked me to make my own video, but today I had more of OPD patients and not an obese patient. I'll just quickly run through what should be the actual RAM position. See, ideally, so ideally they say even in a normal patient, you give head high, only head high. What we make mistake, we make it entirely reverse Trendelenburg. No, it should be just head high. Then the mastoid will come to the sternal angle. But if it is an obese patient, you put a moderately obese, you put a one pillow, it will come in line. And for actual ramp, if you have to give, then you put another pillow below the shoulders. What more I want to emphasize is what mistake we make. While giving RAM, we feel head and shoulder, but we forget that still we should be able to extend the head and still sniffing position should be possible, right? Because many people I have seen when they give RAM, they stand on the stool, they don't take the bed down, and their patient's head is up. The patient's head should be always like that. You should be able to maneuver the head. Yeah. Now, this case scenario, I had a female 30-year-old, diabetes, obese, same, class 2, short neck, double chin for laparoscopic cholecystectomy, MPC2, mouth opening adequate, neck extension was full. So, thyromental distance was normal, mandibular protrusion was normal, upper lip bite test was normal, neck circumference was 40, but she had classical OSA history. This is not her picture, but she had a classical OSA history. दिन में बैठे बैठे ही नींद आ जाती है और रात को 3-4 बार 5-6 बार उठती हूँ. Now, what would you advise? Awake tracheal intubation with fiber scope, awake tracheal intubation with VL scope or a combination technique, or you are confident MPC2 है, mouth opening adequate है, neck extension है, मैं GA दे देती हूँ with McCoy's और video laryngoscope, मैं कुछ कर लूंगी, या फिर insertion of Procil, or nowadays some people feel that they should give segmental spinal and put an LMA, or some are more mature, they feel, no, I cannot manage this patient, I'll send to a higher center. So sorry for the multiple options, but what would you prefer?
So in the chat box, there are multiple answers also. A lot of them have gone up with answer A.
Yes.
So there is also answer, people are also choosing C.
Okay. Yeah. So what happens is, if you are lucky enough, after our sedation and our induction agent, mass ventilation could be good. But remember, it's a physiological difficult airway. The tissues might just fall in because she gives a classical history of obstructive sleep apnea. So remember, an obese patient, the BMI and moreover, OSA decides whether you should go for an awake fiber optic intubation. It is not an overkill in an BMI, high BMI and an OSA patient. Having said that, we all know physiological difficult airway, which includes hypoxia, hypotension. That means what? See, basically hemodynamics. Fluid दो या vasopressors दो. Hypoxia है, then oxygen दो. Right heart failure hai, again it will cause hypoxia, hypercarbia, so treat that. And if there is risk of aspiration, then start with rapid sequence induction. Critically ill patient, OSA, pregnancy. Now, how advantageous are our IDA guidelines? I hope Sheila should have been here because they have really done a good job. They have used AHA class of recommendation and level of evidence. And Delphi method, that means all the experts are unknown to each other. They give recommendations, but suppose I give weak recommendation for some guideline and others give strong, then we ask explanation from others and everyone is blinded. And that explanation is again circulated. So we have graded guidelines this time, our IDA guidelines, and their population intervention and comparison outcome is done. And what does IDA guidelines suggest? A regular simulation should be done. And don't only look for anatomical difficult airway, look for physiological difficult airway. And the most important highlight of IDA guidelines is peri-intubation oxygenation. Pre-oxygenation. Pre-oxygenation हम लोग कैसे करते हैं? As everyone agreed, either we put, when we are loading drugs, we put oxygen nasal prongs, right, to the patient. Or what we can do, if it is an obese patient, we can bring the BiPAP machine. We can give non-invasive ventilation with a CPAP of 5 to 10 centimeters. Or if we are giving through our oxygen through our anesthesia machine, dragger machine, any other machine, workstation, we can close the APL wall and we can give a CPAP of 5 to 10 centimeters. Or if you are luxurious enough, you have a facility to call in HFNO on higher, then you can use Thrive or you can use high flow nasal oxygen. So basically, whatever means, if it is an obese patient, pre-oxygenate with NIV or HFNO, oxygen 15 liters or with Thrive, do that in head high position. Then pre-oxygenation, prime the circuit, they are saying with 10 liters. Again, if you are using an anesthesia workstation, then you have a pressure support ventilation. Use that even during pre-oxygenation at 5 to 15 centimeters with or without PEEP or a CPAP. So maintain ETO2. If you have seen, whenever we do pre-oxygenation with 100% oxygen, even after 3 minutes, the ETO2 does not rise. Actually, I had a video, does not rise more than 90, the expired oxygen. But if you put nasal prongs also, and then give that and put a tight seal, sometimes the ETO2 might rise. Now from here, I'll be going fast. First 10 minutes are over. 10-15 minutes, another 10 minutes, okay? Now, first attempt, of course, we all know a video laryngoscope, Buji, Stillet. Now, what does IDA guidelines say? They formed in first 2016, they were linear. It intubation try karo, फिर supraglottic try karo, and अगर कुछ भी नहीं हो रहा है, then continue on mass ventilation and prepare for cricothyroidectomy. But now what they say is a circular path. At any time, there is no hierarchy. At any time, suppose a new anesthesiologist comes in and he wants to try intubation, they can try. Or someone feels they are expert in putting a supreme, they can try in between. So they say any rescue device without hierarchy, 3 attempts if saturation is more than 95%. And when there is complete ventilation failure, initially they had advised any cricothyroidotomy. Now they advise emergency surgical cricothyroidotomy. Again, that same guidelines. Another important thing which they want us to keep is track of time and saturation of oxygen. You tell someone, like once I had a fracture C6, C7 and cervical collar and I was doing awake intubation. So I told my junior most, my student, you just do one thing. Look at the monitor, oxygen 95 के नीचे जाएगा बोलना, and every 1 minute you tell me the time. So you can align some person to that. So what does IDA guidelines say? Human factors are also more important. अच्छा, सबसे important है when you are intubating, you have called second anesthetist, third anesthetist. Everyone gives their opinion. So remember, you have to keep cool. Sometimes you may tell them also, wait, let me make decision, I will tell you. It's no harm. So there should be no loss of situational awareness. Keep track of time and saturation. Always brief your team. Anesthesia technician है, उसको बोलो ये difficult airway है, मैं एक के बाद ये मांगने वाली हूँ. Yeah, whatever, the sister who is there. So flattening of hierarchy and vortex approach. This is what the IDA guidelines say. We have 3 types of cricothyrotomy: surgical, needle, and wide bore. This is the stab and twist. That means you stab at the cricothyroid membrane. Then the next slide will show properly. You stab. Then you turn it. See, first you stand on the left side of the patient. Then you put a stab. You put a stab, then you put a stab, then you turn it. Make it vertical with the blade going caudal. Then you make room for the bougie. Turn the blade to one side. Make room for the bougie, and over it guide 6-number endotracheal tube. These are some of the caveats I wanted to ask Sheila, that why they have said that don't waste time in neuro putting check ventilation. I don't know what was the thought process behind that, but IDA guidelines say that you need not do check ventilation. What I feel is maybe they want to say, even if like my first case, where the anesthesiologist had check ventilation normal. So though the check ventilation is normal, it does not assure that you will have a normal intubation. That is okay. But why they say avoid check ventilation, we'll have to ask them. Again, they are suggesting that use Sugamadex only, and succinylcholine may not be useful. But Dr. Manisha, like your Ahmedabad's lecture, that Fatma Sugamadex loading will take time and action also will take time, similar to succinylcholine. Then pre-oxygenation. Then one more important thing which they are saying, which we are misinterpreting, is 20-degree head-up position should be there and not the entire reverse tendon work. Then you lose the advantage. And remember, okay, one more thing. I had one friend who was inducing ankylosing spondylitis, and he said, "Mala video laryngoscopy त्याच्या वरती उभं राहावं," and I had to bend. Remember, with video laryngoscope, you may not give this ram position or head up position. You can use a normal position. And whatever said and done, I remember 8 years back, no, suddenly, अरे sniffing position बेकार है, 3 axes align नहीं होता है, कुछ नहीं. But even today, even if the axes align, don't align, the sniffing position gives best intubation score. The intubation difficulty score is good, means it is less, there is less difficulty with sniffing position. Remember that. Now, advantage of, now I have told you the advantage of IDA guidelines, its shortcoming. So now DAS guidelines, advantage. They have lot of advantages. I'm sorry, but I'm not blaming the Indian guidelines, but we should take from them that they have created. Yeah, so they have created air bites. Now, what is air bites? Like this, a 15-minute session. What they say, do regularly. Take regular sessions with each other. Actually, we can suggest Avinash sir that, monthly we can have something like a discussion, revision of the guidelines. So air bites, then air drills. So all these videos and everything, except for some educational videos, most of the things are uploaded on difficult airway DAS guidelines, and please go through it. It is a lot of information material. Fine. So this way, all the air bites are there. Now, what are the advantages of DAS guidelines? Because I'm here to compare. Now, what they say, other things, okay, bedside MPC karo, mouth opening, neck mobility, these all are common. Upper lip bite test is also important. What they say is, if possible, check for a nasal endoscopy. So after reading those guidelines, we had this vocal cord tumors and all. Before that, we just used to check, are ideal kya hai, kya hai. But then I started checking, even our ENT people have progressed. Abhi un log OPD basis mein kar rahe hai. So why not see that? Why not send our patients also for that? And awake video laryng. Dr. Manisha, you can just tell me how much time is over and whether Sheila has joined.
Sheila ma'am has joined, but we have time, ma'am.
Okay, so maybe last few slides. Yeah. So nasal endoscopy and awake video laryngoscopy is important. You can call the patient to your OT any day preoperatively, either spray and then do a video laryngoscopy, or start a small dexmedetomidine or remifentanil drip and do. Even if you are not using sedation, you are doing totally awake video laryngoscopy. Remember, you have sprayed the vocal cords. The patient will have a feeling that he is not able to swallow, may have a choking feeling. So unless that feeling goes for under 2 to 3 hours, do not send the patient home. Then what does DAS guidelines say? Other imaging also you check. USG, though USG had a steep curve, suddenly coming up for airway, but they say that it is still not taken up so much. The distance of epiglottis or the distance between the hyoid and the mentum. But what you can do is you can mark the cricothyroid membrane. And this is very useful in all difficult airways. What I do is preoperatively, when I see them, they are lying supine, tell them to extend the head and then palpate with your finger, thumb and the index finger handshake and mark the cricothyroid membrane. And what DAS guidelines say, even when you are pre-oxygenating, see if capnography is coming, you will come to know that the airway is clear. Keep a checklist ready. Consider ATI, always awake tracheal intubation if possible in a difficult airway, physiological difficult airway. Keep all the audible tones high. First failed attempt. Remember, don't keep on attempting. You have to remember at the back of your mind, keep supraglottic airway device ready and accessible phonak kit, face mask ventilation to maintain oxygen. Though it says a linear scale, still it says anytime you can go back to face mask ventilation. Capnography. IDA says only capnography. They say capnography and visualization of the vocal cord. This is the checklist. This is the plan. It's there on the internet. Main thing again in both the guidelines, stop and think. Do not hurry. Mask ventilate the patient, right? Maintain saturation at 95. Yeah, these are the various grips. CE grip, two-handed grip, then wise grip. There is something called which is there in the DAS guidelines. This is basically jaw thrust, but jaw thrust and with C. So it is a wise grip and CE wise grip. Now, there is a big difference. First, we saw, which Sheila also advocates, is stab cricothyrotomy, where you do a stab knife and then you turn the knife, you make a space for the bougie. Here, what DAS guidelines says, suppose the identifying the cricothyroid membrane is not easy. Suppose it's not an obese patient. You have not marked it. Then what? Then make a skin cut entirely from mentum to the thyroid to the sternum, and then locate the cricothyroid membrane, do a stab incision, and then the procedure continues. In this case, I can omit where the awake video laryngoscopy was done pre-op because she had fusion of this vertebra. You can see, she said, I have one fusion of the vertebra. This is what DAS guidelines gives, that you should have this emergency tracheostomy chart and tick everything. Obesity, remember, you cannot take it lightly. Whenever possible, do awake tracheal intubation if you feel. For pre-oxygenation, head up and other things we know. High flow nasal oxygen is must for pre-oxygenation and early use of supraglottic airway device. Yes, and this is the infographic of ASA guidelines, which Sheila wanted me to emphasize. They have a nice infographic where they say that suspected difficult laryngoscopy or intubation, or with direct or video laryngoscope, that you decide first. If yes, then decide whether face mask ventilation will be there. See, the other these mnemonics are there. How there is difficult face mask ventilation, how there is difficult supraglottic device. So you see, if it is difficult, then if it is no, then proceed. If yes, then awake. Again, increased risk of aspiration, go for awake. Increased risk of desaturation, go for awake. And if you're not going for awake, again, review airway strategy. If you're not going, if you're going for successful awake intubation or failed tracheal intubation. So it is awake non-emergency pathway where your awake intubation have failed. Then you have to decide if the patient is unstable, if you want to postpone the case or you want to continue and you want to induce the case or put an emergency in invasive airway. Again, this pathway, emergency pathway, where you decided to induce the patient and your airway plan was unsuccessful, then what? Then again, you have to have a vortex approach where you try supraglottic airway, tracheal tube or face mask till the saturation is more than 95% and ventilation remains adequate. If it is inadequate, then go for surgical cricothyrotomy or another, again, rigid bronchoscopy, ECMO, and many other invasive procedures. So this is my last slide. What we have to do, what I will change in my practice. In my practice, airway history, I used to ask previous difficult airway, but I will consciously now ask the history of obstructive sleep apnea. So I know my mask ventilation is difficult. Still, my PAC paper does not have upper lip bite test, but in a difficult airway, if I see, I'll try to ask them to do it. Again, I have to mark cricothyroid membrane, and that I have to mark with patient in supine and head extended. I have still not, my head is still not fixed that I have to assess every day pulmonary aspiration risk, physiological difficult airway, and I can as well ask for a nasal endoscopy and as well do myself awake video laryngoscopy. Other things are same, pre-oxygenate, per oxygenation, minimal sedation. Remember, as Dr. Manisha Singh said in her talk, आप प्रोक्रोनियम से आपने सुगामाडेक से बाहर तो लाया भाई, अगर
But after
सेडेशन,
airway patency.
हाँ, भरा हुआ सेडेशन दिया है तो कहाँ से पेटेंसी आएगी? So remember that minimal sedation when you see a difficult airway. Video laryngoscopy first attempt with Buji and Burke, and stop and think. Think and do not, there should be no clouding of the mentation. You should think clearly, call for help at first non-failure. Call for surgeon for tracheostomy at first non-failure. Keep ready scalpel, Buji, ETT at first non-failure. And awaken the patient is also an option. Remember, don't keep on trying. And if one take-home message, if you have to take from my talk is, if there is difficult intubation, remember, you have tried mass ventilation. You can mass ventilate the patient for 45 minutes also, instead of losing the airway with repeated attempts and bleeding, secretions, and edema. Thank you very much. I'm sorry to take your longer time.
No, it wasn't actually at all. And nobody looked at the time, I'm sure. So thank
Sorry.
you. It was a very great, insightful session. Actually, you have simplified a very vast and a complex topic, especially the three different guidelines you have jotted down and help us form an individual guideline actually for
Yeah,
our own self. Like,
I'm sorry, Sheila, if
although-
I went wrong somewhere.
No.
Yeah.
So especially when in such situation we are unsure of which guidelines to follow, which method to follow, I think you have actually jotted down all the three and framed your own complex, simplified version of the complex guidelines and what we are comfortable with, and we should always choose best what we are best in, I feel. And the shift to the awake tracheal intubation and video laryngoscopy has been quite evident in your slides now. There was one question. Should we be taking all the airway questions after Sheila ma'am's
Yeah, we'll take after Sheila's lecture. Yeah,
All
Dr.
right.
Sheila's lecture. Yes.
Bhavesh sir?
Hello, good evening.
Yes, sir.
In day-to-day practice, actually, everybody are masters of laryngoscopy, but some or the other times we must have felt that we have landed in a situation where we have an unanticipated difficult intubation, which is the crux of this topic. And I welcome Sheila Maitra, a renowned difficult airway speaker. She is a professor of anesthesia in critical care medicine, DMH. She is a past president of Indian Critical Care Society and of Medicine in India. Also, she is the author of All India Difficult Airway Guidelines. And what we are very lucky to have her to present us this topic of unanticipated difficult intubation. So, Sheila, carry on.
Yeah, thank you very much, Bhavesh. It's really a pleasure to be here talking to all of you. And I'm, first of all, apologies for reversing the order of the talks because I got a little late in traffic. But after listening to Shilpa's talk, I felt it was in the right sequence. So she covered a lot of topics, a lot of things related to basic airway management and preparation for airway management, which I think is very helpful. I hope you can hear me well, and I hope you can see my slides.
Yes, Dr.
Slides?
Yes, yes, Dr.
So what I'm going to do is I'm going to talk to you about the Indian Airway Guidelines. And that's brought to you by the All India Difficult Airway Guidelines. And a lot of people say your guidelines, but I think we should say our guidelines. And I think we should be very proud of our guidelines, not because, we've made it or something like that. But, just yesterday I was looking at the COPA meeting in Brazil, and they were presenting the Indian guidelines. And I was just so proud to see that, So they're not taking our guideline because it's DAS or it's ASA. They're taking a guideline because it really is good or it makes sense or it's practical for application. So like Shilpa rightly said, that you have to take the good things from all the guidelines and you have to make something that works for you. So last week I was in Marrakesh and I presented our guidelines and I was asked, why did you make Indian guidelines? When you have ASA and when you have DAS, why did you need to make another guideline? This was a question asked to me from somebody in Africa. And I said, it's not, I said, did you ask that question when DAS made guidelines? Or did you ask that question when the Americans made the guidelines? I said, it's not about Indian guidelines or American guidelines. It is, we try as airway managers to get better and better and better and improve the safety of airway management in our patients. So if we think that something needs to be modified or something can be done better, that's the time when you feel you need to revise the guidelines. So that's the way I look at guidelines. I don't look at them as Indian guidelines. I look at them that is as something that can be practical for anyone to apply, for safe airway management practices. So before I start, I want to, talk about a real case. And this is something I was involved with. And this was the patient who died during an airway incident. And I was called as an expert. And I really want your perspective on this, okay? So this is a 67-year-old male, 32 BMI, no comorbidities. And I come in from a cancer hospital. As you know, I work at Tata Memorial Hospital. And this patient had a previous tongue commando surgery and he'd also received radiation, okay? And this patient had a recurrence on the left border of the tongue and was for an excision. Airway was unremarkable. Mouth opening was 3 fingers, nice wide mouth opening that he had. Now, a nasal intubation was required. So there was a small recurrence which had to be excised by the surgeon. So direct laryngoscopy was used for nasal intubation, but it was difficult to intubate this patient. And there were 2 failed attempts at intubation and the saturation fell to 88. But patient was reoxygenated using a mask, which was again easy, and a video laryngoscopy was used. But even with the video laryngoscopy, intubation was not successful. So a supraglottic airway device was inserted because the patient, was not maintaining saturation. Successful ventilation, saturation came up. Whatever patient had desaturated, but after reoxygenation, saturation came up to 100%. And then this patient was being nicely ventilated, saturation is up. So a senior airway manager came in, and that senior airway management manager said, let me attempt intubation, and removed that supraglottic airway device and then attempted the intubation. And then even with a video laryngoscope, there were 3 failed attempts at intubation, and intubation was absolutely not possible, and oral bleeding started for this patient. So supraglottic airway device was attempted again, but this time it was unsuccessful. The saturation went down to 86%. Mask ventilation was also tried after this, but it was not successful. And patient continued to desaturate, and patient had bradycardia and had a cardiac arrest and arrested on table, and this patient could not be resuscitated. So this was a very tragic case. And there are many lessons learned. When I look at this kind of case, it's sometimes quite a frequent occurrence. in a lot of areas. Of course, the outcome is not so disastrous. We're able to somehow rescue the situation. But I just want to know from you, anybody, what could have been done different in this setting? I'd just like to know your thoughts. I won't be able to track the chat, so if, maybe
Fiber
Manisha or
optic
Shilpa can
through
help me.
fiber optic through the supraglottic airway. Attempt of fiber optic through the supraglottic.
Right, okay. Yes, so you mean to say that that supraglottic airway device should not have been removed? That's what you're saying,
Yes.
right? Okay, that's a very, very important point. So what tends to happen is when you have been able to establish successful, remember, intubation not intubating doesn't kill the patient, not ventilating does, not oxygenating. When you have been able to successfully ventilate the patient, it was a wrong decision to take out the supraglottic airway device. Never take out a supraglottic airway device when you've established successful ventilation. And if you want to intubate, supposing it was not supposing it was a surgery, say a abdominal surgery, and the surgeon wants a tube in, it has to be done through the supraglottic airway device. And there are many ways by which you can do this. So never remove the supraglottic airway device to intubate the patient when you achieve successful ventilation. And you have time. Your patient is saturating well. You have time. You can paralyze the patient. You can continue the ventilation. So there are two ways of doing this. So to intubate through the supraglottic airway device, you could use, so a lot of people say fiber optic scope, fiber optic scope. So I just want to make a point that this has changed the terminology because we don't use fiber optic technology anymore. So they are fiberless scopes. So we say flexible bronchoscope now because very few fiber optic scopes are left. So you could put the tube through the supraglottic airway device over a bronchoscope, put the bronchoscope into the trachea and railroad the tube over. But that is not possible through all the supraglottic airway devices, right? It really depends upon which type you have used, what is the diameter, what is the alignment. So it may not be successful at all times. So you also have another tool. Does anyone know what tool you could use to intubate through any supraglottic airway device? Even a Supreme. A lot of people use a Supreme. So then, how are you going to intubate through that, right? Anybody can tell me? Can you hear me? Is there anything in the chat?
Nothing in the chat.
Yeah. Okay. So there's a very useful tool, and that's called the Aintree Exchange Catheter. Okay. This is a tool that was developed in Aintree, AINTRE, and that's why it's called the Aintree Exchange Catheter. It's simple. It's something that looks like a bougie, double the length of a tube, hollow. Okay. And this is specifically used for intubation through a supraglottic airway device. Now, we don't use it because we are not aware of it, or we don't keep it, but it's a very, very useful tool to have in your armamentarium. Is an Aintree exchange catheter. Unfortunately, I don't have an image of it now. So what we could do is we could put, the slide, it's like a hollow sleeve, double the length of a tube. Okay, something like a bougie, but hollow. So you just slide it over, put it like a sleeve over the bronchoscope. Okay, and then put both the bronchoscope and the, with the Aintree exchange catheter covering it, coating it through the ventilating port of the supraglottic airway device. Enter the trachea, right? Once you enter the trachea, remove the bronchoscope, okay? And then deflate the cuff of the supraglottic airway device, remove the supraglottic airway device. Now what you have is like a bougie in the trachea, and then you can slide any size tube of any diameter into the trachea. So the advantage of using an Aintree exchange catheter, it doesn't matter which supraglottic airway device you put. You're not limited by the internal diameter or the type of supraglottic airway device or even the type of tube. Like when earlier we used to use the, intubating ILMA, etc. We had to use a flexible, specific kind of tube. Here you can use any kind of tube. You can use a Portex tube, you can use a Rush tube, you can use any kind of tube that you want of any diameter. So this is a very useful tool to have in your armamentarium. And I know in India we, gas sterilize it and use it. Otherwise it's for a single use, but this is something that can really save your day. So the message I want to give you that if you put in a supraglottic airway device as a rescue, never remove it to intubate the patient. Always, if you need an intubation, you should try to intubate through the supraglottic airway device. And this is universally what all guidelines say. All guidelines say this. So that was just to address that. Is there anything else that could have been done differently? So I think the biggest mistake was to remove that supraglottic airway device, and intubation should have been done through that. Any other learning from this?
You could have done directly first an awake fiber optic itself.
Yes, absolutely. And Bhavesh comes from Tata Memorial Hospital. So, this patient, previous tongue commando and post-radiation. Remember, post-radiation, we're not taught about radiation in anesthesia practice. I mean, we're not taught about, but radiation affects every part of the airway. It makes the tissues non-compliant. There's fibrosis, there is edema, there is a lot of changes that radiation does to the airway. So you have to be very aware of this. And when you have a patient who's post-radiation who comes for surgery, it's a red flag. Just think this airway is going to be difficult. This is going to be difficult. So don't just get fooled by the mouth opening or all the other airway tests that you're doing in cancer patients post radiation. The first thought that you should come to your mind is this is going to be a very difficult airway. The tissues are often non-compliant. Even with a video laryngoscope, sometimes airway can be difficult, right? And you have a previous tongue commando surgery. So part of the mandible is removed. So mask ventilation is going to be difficult. So it is like the, mind does not, eye does not see what the mind doesn't know. So if you're just going to say, okay, muh kholo, mouth opening 3 fingers, everything is fine, I have video laryngoscopy and I will, then that may be this thing. So absolutely, you can straight away have used a flexible bronchoscope to do an awake intubation, which is a gold standard for any anticipated difficult airway. But the thing is, the airway operator didn't anticipate this to be a difficult airway. So anything else that could have been done? Anything else at any of these stages?
Since it was an elective case, we could continue with ventilation till awakened and
yeah, you could do that. So it is absolutely not wrong to continue with the supraglottic airway device or even do a tracheostomy. Call a surgeon and do a tracheostomy. That's fine in an extreme situation. I'm not saying doing tracheostomy for all. But see, today we are moving away from airway device. Sorry?
If you had a Thrive, we could have used it.
Okay, now I want to come to Thrive. Yeah. So today, when I trained in anesthesia, the person who could intubate was a hero. It was all about heroics. Who can put the tube in? Who can do the best intubation? Today, we have moved away from heroics to safe airway management practices. You don't want that 0.0001% chance also that the patient can die. So we are away from people who are just, heroic and very bindas. Like I managed somehow I intubated the patient to people who are very safe. Because if you think about yourself and what you would definitely want someone who's very, very safe and keeps you 100% safe. So one thing about Thrive, and Shilpa did touch on Thrive. So when you use Thrive firstly is not a rescue device. Yeah, Thrive will not work in a desaturating patient. So for Thrive to work, for any high flow nasal oxygen technique to work, you need 3 things for success. One is good positioning. So you give good propped up position. And the reason for this, and Shilpa already talked about the positioning, is why we don't like to keep our patients flat is because, in the posterior, in a flat position, the posterior portions of the lung are more prone to atelectasis. And this is also the position in which the patient is more comfortable. So proper positioning. The other thing is you have to have had good pre-oxygenation. Your FRC should be filled with oxygen, and then Thrive will continue your apneic oxygenation, your safe apnea time can be prolonged. If your FRC is not filled of oxygen, Thrive will not work, okay? So you need pre-oxygenation, adequate pre-oxygenation. And the third most important thing for any high flow nasal oxygen to work is you need a patent upper airway. Without these 3 prerequisites, high flow nasal oxygen doesn't work, right? So in this situation as a rescue, you cannot use high flow nasal oxygen, yeah? So, anything else? I think probably seeing this
Rigid.
head and neck case, how many of you would go with a VL upfront in this case? Would you? Or would you try DL and then fail and then? So I think this kind of case, the head and neck case previously operated, warrants a video laryngoscopic insertion. Anything else? No other thoughts?
Tracheostomy.
Yeah, I mean, what could have been done different? I mean, what went wrong with this? Yeah, a tracheostomy could have done after the supraglottic airway device. Now, 3 failed attempts. So again and again, the airway manager, I think Shilpa emphasized this. There'd already been 2 attempts, and again they did 3 more attempts, and now the oral bleeding started. So, you put yourself in a very tricky position. This patient could be mask ventilated easily. This patient, SJ fitted perfectly. So you had 2 of your lifelines already there, but you burnt all your bridges because you went on and on with attempts at intubation. The oral bleeding started, and the SGA that you could insert, you're unsuccessful in that now, and the mask ventilation will also become difficult. So remember the reason why we say limit attempts. Someone would think I'll go on reoxygenating the patient. Now, what difference that make if I do 10 attempts at intubation? Is because you have trauma. you have edema, and you change a can ventilate situation to a cannot ventilate situation. And that is a reason to limit the attempts at device insertion. It's really, really important, whether it's a tube or whether it's a suprachoroidal airway device, we don't want to exceed, and all guidelines emphasize this. So this was really unfortunate because the reoxygenation was not possible. So it was not the tracheal intubation, that not being able to intubate that killed this patient, but not being able to mass ventilate, and not being able to ventilate, and not being able to oxygenate. So I think there was a lot of learning from this case, right from the way the plan was made to many other parts. So this is the kind of situation. So well, someone would have said this is an anticipated difficult airway, but for this person, it was an unanticipated difficult airway because they never anticipated that this might have been, that this is a difficult airway, a head and neck case. So this, I like this cartoon very much because this is, the situation. And when you look at it only, you understand, you see the airway operator, you just look at him, how stressed he is, You see the patient is blue, and you see the person, that assistant is also frozen. So this is a lot of human factor consideration when you reach this situation and look at the monitor. You always think that this is never going to happen to me, or this will never happen to me today. But when that happens, you absolutely freeze. It's very well known that it's not only your technical skills, but your non-technical skills that come into play. And, people start screaming and shouting, and, you lose the big picture, and you start having a lot of cognitive overload, and you have tubular vision. You keep doing the same thing again and again. You will see, sorry, the most senior people will go on taking the DL, or they will not think of putting a suprachoroidal airway device. They'll go on doing the same thing again and again. So because of the huge cognitive overload, you're thinking, oh my God, I'm going to lose my job. Oh my God, the patient is going to die. Oh my God, what are people going to think about me? So there are a lot of thoughts that come in your mind, and because of this cognitive overload, you're not able to act effectively. And sometimes a very junior person might come in and say, why don't you put in a suprachoroidal airway device? So in the Ellen Bromley case that is classically talked about in all these airway workshops and situations, the junior had the cricothyrotomy set, was not bold enough to talk about it. And Shilpa talked about flattening the hierarchy, and that's really, really important in India. We don't encourage junior people to speak up. We always, the madam or the boss is always right. So that's really, really important in crisis management, especially when you're faced with this kind of situation. Now, to be sure that, you're not, you can manage this kind of situation properly, it's very important for us to have some guidance or guidelines, because at that time, you don't want to look up the evidence. The time is essence, and you don't want to think about, oh, now what am I going to be doing, right? So you must have, like for cardiac arrest, a sequential, time-sensitive interventions that you need to do, which are reasonably evidence-based. And that is why you need airway guidelines. And that is why guidelines for unanticipated difficult airway are, very essential and are very popular, because, for anticipated difficult airway, you still have time. You can phone a friend, you can get a friend, you can get a device. But unanticipated difficult airway, often you may be alone, and that's the reason we need guidelines. Now, Shilpa alluded to the ASA guidelines, and these are good guidelines. And I'm really proud. I was the first non-American to be a part of these guidelines, and I'm really proud of this. What I was not proud about is that we made some we made some algorithm for the ASA. And unfortunately, at the very end before publication, and nobody knows this, they thought that the Americans would not be able to understand it, what Shilpa was showing as the infographics. So they converted this into infographics, and what they actually took the old ASA guideline, which was 10 years old, and they just made some subtle changes, which has a lot of branching tree appearance. I don't have the algorithm here, but you know what I'm talking about. And, that, was really something that people in 2023 think is absolutely useless, because it really doesn't change much, just a few things about attempts and very subtle changes, but it's essentially pretty much the same. But what we had made for the algorithm was actually the infographic 1, 2, and 3 that nobody even looks at. And I want to allude to this infographic one, because I was responsible for making this, and I'm very, very proud of this. And we always talk about managing an unanticipated difficult airway. But you know what we should focus on? We should focus on preventing an unanticipated difficult airway. How to prevent it? And why does this unanticipated difficult airway occur? This unanticipated difficult airway occurs because you have given general anesthesia and you have given a muscle relaxant. And now you are in a situation where you cannot intubate this patient and you cannot ventilate this patient. And now you're in an absolute crisis situation. But this situation would never have arisen if you had not given GA to this patient, or if you had not given muscle relaxant to this patient. So the important way to prevent this is to know which patient to do awake and which patient to do asleep. And that is the real training that we need. Because a lot of people are very bold because of like the case I showed you. And like Bhavesh rightly said, an awake flexible bronchoscope could have been used for this patient. And this would have really saved the day. This was probably an anticipated difficult airway that should not have been given general anesthesia. So it's this infographic actually tells you about the pre-airway management decision making. And it's a very objective, very simple tool that before you do any anesthetic, any airway management, you ask yourself 3 questions. So if it is, say, suspected difficult laryngoscopy or intubation with direct or video laryngoscopy, ask, is it difficult? Okay, if your answer is yes, next question you should ask yourself, is this mask ventilation easy? Can you mask ventilate? Can you, so, an intubation may be difficult, but if mask ventilation is easy and supraglottic airway device insertion is easy, then I'm still okay. Even if I fail an intubation, I'll still be able to ventilate the patient, right? The other question you ask is there significantly increased risk of aspiration? So this is also extremely important. And is there a risk of desaturation? Now, is this a physiologically difficult airway? Now, when you talk about a physiologically difficult airway, what is a physiologically difficult airway? A physiologically difficult airway is one in which physiological or pathological alterations increase the risk of complications during tracheal intubation and transition to positive pressure and ventilation. So your critical illness, your hypoxia, in critical ill patients, you see hypoxia, hypotension, you see right ventricular failure, metabolic acidosis, raised intracranial pressure. All these constitute a physiological difficult airway. Also, certain other physiological alteration like obesity or pregnancy, which also reduce your FRC, also shorten your safe apnea time, they also constitute a physiologically difficult airway. So these are the 3 questions that you ask yourself. Now, if your answer is yes to these questions, straight away you consider doing an awake airway management. And if your answer is no, you can consider going ahead and inducing the case. And the beauty of this is, the answer is yes or no, depending upon your expertise and also depending upon what devices you have in your armamentarium. For example, if I say yes, mask ventilation is easy, for my first year anesthesia resident, the same thing is no. For him, it's not easy, right? So this decision-making tree is actually variable depending upon what is your level of expertise. And that is why it's very dynamic. It's not static that the answer will always be the same for every individual. And it also depends on what is the setting and what is the context in which you're answering. So I think the decision-making tree is good because we just look at the patient and say, ha, ji de de, ha, awake kar do. We don't objectively ask ourselves and put ourselves in these 3 questions. Okay, ventilation is easy, so I can go ahead and give GA. Now we have video laryngoscope, so we are more and more bold and using less and less of flexible bronchoscopy, and we're using more and more of video laryngoscopy to intubate patients. So if my mask ventilation is fine, and I think, okay, I can put in a supraglottic airway device, I wouldn't be nervous about using a video laryngoscope, even though I anticipate that this may be a difficult airway. So I'll now move on to the All India Difficult Airway Association guidelines. And as you know, this is not the first time we did it. This is a revision of the guidelines. So this was published in 2016 in the Indian Journal of Anesthesia. And we were really commended because we made not 1, but we made 5 guidelines. We made 4 guidelines. One was for adult, then we made obstetrics, we made pediatric, and you can see a similar kind of linear flow, but only the color was different. So you know that if it's pink, it's obstetric, if it's lilac, it's pediatric. We made a very comprehensive extubation guidelines. And, I really urge you to see the updated guidelines because we have really been given a lot of credit for this. If you see the DAS guideline, there are 3 different pages for 3 different situations. Whereas if you look at this, I challenge anyone to tell me one extubation situation that doesn't fall into the extubation guidelines. So really robust guidelines. It's been modified a bit in the new iteration. And I'm really proud to say that the first guideline for tracheal intubation in the world comes from India, comes from IDA. No one had made a guideline for tracheal intubation for ICU, acknowledging that these patients have a physiologically difficult airway. So we're very proud of these guidelines. So why did we really need guidelines after 10 years? And if you look at the previous guideline, huge focus on peri-intubation oxygenation. We were the first guideline that talked about give oxygen throughout, give nasal oxygen during attempts at intubation, even before any society talked about them, limiting the attempts of intubation at device insertion. And I told you why this is so important. We talk about saturation threshold. Now, guidelines talk about 3 attempts, 4 attempts. They never talk about what is your saturation threshold. When I say 3 attempts, means I have 3 attempts. I do the first attempt, the saturation is 80. Do I go on with the second attempt? Do I go on with the third attempt? So the importance of reoxygenating between attempts is really, really important. So it's a very reoxygenation focused guidelines. We don't just say 3 attempts, but we say go ahead with your next attempt at intubation only if the saturation is more than 95. And we define a new term, and this is complete ventilation failure, which I'll talk to you about because I know a lot of you use cacophona which Puma has actually, thrown out of the window because it's an inappropriate terminology. And I'll tell you why that is so. Calling for additional help during complete ventilation failure. Now, when you reach the situation that you have complete ventilation failure, IDA recommends that you call for additional help. And this additional help is not because you have one more helping hand, but it is to address the human factor considerations. At that time, all the people in their room, their heart rate is, don't ask what, they're so stressed. It is that additional help is not only as a helping hand, but also to the person who's not in this mess, who can think straight and can help in this situation and think differently from the people who are already in this mess. And in fact, the American Society of Anesthesiologists liked this so much from IDA that they incorporated this in the ASA guidelines. So they have a call for additional help when you reach the stage when you're doing the cricothyrotomy. And then at that time, nobody in India was doing cricothyrotomy. Even today, when you say, oh, I failed airway, they say, surgeon ko bulao, tracheostomy karo. So tracheostomy is not emergency airway management, right? What you need to do is a cricothyrotomy. Tracheostomy needs a surgeon, tracheostomy takes time, tracheostomy needs light, it needs cautery, it needs positioning. The reason we say cricothyrotomy is because it's easy access, it's a cricothyrotomy membrane, anybody can do it. And at that time, no anesthesiologist, no airway operator was even knowing how to do it. So we said, okay, whatever technique you're familiar with, do it. But please transition from upper airway to neck rescue immediately. Do a cricothyrotomy. So whether it's a needle cricothyrotomy or it's a surgical cricothyrotomy or it is using any of the commercially available kits, we said whatever you have, please use it. So we had all this already in the guidelines. So why did we need the 2025 guidelines? So this is an updated version of the guidelines. So of course, over 10 years, technology, there's so much updates, additional evidence, devices, and also changes in our clinical practice have occurred in the last decade. Now, the previous algorithms, and this is the most important change, they provided guidance only for a failed intubation. And a lot of people told us, especially private practitioners, that I don't intubate all my patients. I give TIVA, I put a supraglottic airway device, I use mask ventilation, or, so your guidelines only talk about a failed intubation. But what if I give some other form of airway management? So what about what is the guidance for that failed? And that really got us thinking. And we said, why are we only giving this linear approach and only talking about a failed intubation? So we said we have to make it something that is not intubation centric, and we have to move away from this. And I'm really proud to say that they were the first guideline in the world who has moved away from a failed intubation, because that is not a primary airway plan for all anesthesiologists. And for the extubation guidelines, people say difficult extubation. There is nothing like a difficult extubation. Pulling out a tube can never be difficult. Okay. So it is a misnomer. An extubation is not difficult. What you're worried about is the at-risk extubation. That is the extubation that is a risk of reintubation. That is a risk of failing. So we needed to do, guide people to have proper risk evaluation prior to extubation. Who is the patient who's at a risk of extubation, and what are the things that you can do to mitigate that risk? And that is the reason we made the extubation guidelines. And of course, as already has been alluded to, increasing use of ultrasound, and we have Sugamadex. So we had to think about all this when we are refining, updating our guidelines. And Shilpa has already talked about the process that we went through. So we had a very robust methodology, and I'm really proud to say that it wasn't just 10, 15 people sitting together and making a guideline. So it was based on a very robust literature review. We had a systematic literature review, data extraction, evidence synthesis. We looked at PubMed and Scopus right from 2000. All papers were screened. Each paper was screened by 2 members of the committee, and they independently screened and reviewed this. And then we made a list of abstracts, and then from that full text was screened. And we didn't use grade recommendation, but we did give grading. So we used the AHA class of recommendation, and we also gave level of evidence. So I am very proud to say that the ASA does do grading, but no other guidelines does. ASA does the most rigorous literature search ever, because working with them, I realized how much importance they give to the literature review. And, they would never do a guideline like DAST, just where people have their opinions. So we tried something in between. Of course, we didn't have such good methodologists to do a grade recommendation, but we at least gave a level of evidence. So for each PICO question that we asked, we had a concept table, search string, and we had PIRMA flow chart. So this is the AHA class of recommendation. So every guidance that we gave a class of recommendation and also a level of evidence. So I'll put you through this very quickly. Now, there are also, for everything you cannot give grading, because there are some interventions for this which there isn't good evidence. Should I do 2 attempts, or should I do 3 attempts, or should I do 5 attempts at tracheal intubation? So for this, the next best thing you can do when you don't have good evidence is to use Delphi methodology. And we conducted a very robust Delphi process. And what is a Delphi process? Is you have a steering committee and you have experts. So we took experts from across the country. So it was not part of the steering committee, the committee that we had. And you make a group of these people, and the steering committee doesn't participate in the voting. And the experts, they are anonymized. So one expert doesn't know the other expert. And this is very important because you avoid any group pressure or any kind of bias when you anonymize the experts. And what we did is you have iterative rounds. So you need at least 75% consensus for that thing to, for you to say that there's a consensus on the statement. We had multiple choice questions and we had Likert scale questions on a scale of 1 to 7, and multiple choice with single or multiple choice answers being correct. Now, you don't only look at consensus, but you also look at stability. So in each of the rounds, you go on repeating the same questions till you achieve not just consensus, but stability. Just to give you an example, and I don't want this to be a methodology class. So in round 1, supposing for the same MCQ, I give answer A as the correct as the answer. I choose that as an expert. But in the next round for the same question, I option D. So there is no stability between my responses, okay, between round A and 2. So this question will continue. So the questions continue till consensus and stability are achieved between the responses. So you're really sure that the expert actually wants to say this and is not just, choosing any other answers. So based on those items that achieve consensus, and remember, we put only those items in the Delphi process which did not have good evidence. Wherever the evidence was good, we used the literature, we used the grade system. So, and then from this, we developed expert consensus statements from whatever achieved consensus. So, in our algorithm, if we are using 3 attempts, it was based on consensus, Delphi consensus. If you're saying use VL over DL, it was based on a grading. So, we're very proud because the methodology is very robust. Not compared to ASA, but definitely compared to what they're asking. In fact, we like this so much that we published a separate paper on the guideline development process, because the editor of the journal said that, you've done such a good job with this methodology, so why don't you publish the methodology separately, so it will serve as an exemplar for other people who want to make guidelines. So I'm going to be talking to you about, not only if you have time and you're interested in this, do read the guideline development process and also the Delphi methodology. A very robust process was followed. But I will talk to you about the adult guidelines now in the next 20 minutes. So this is what the algorithm looks like. Very, very different from what we had previously. We just had a linear format, but now it's like completely different. And there are nice bright colors, as you can see. I'll talk about adult, and most of our guideline obstetrics pediatric look the same. The only difference is the background. You can see this is light blue. When it is obstetrics, it's light pink. And when it is pediatric, it is a lilac color. So the moment you look at it, you know it's a guideline for adult or pediatric, or it is for obstetric. So here I'm going to talk to you about adult guideline. Now this is before I go talk to you about the guideline, I'll just talk about which are the best practice statements that we achieved. So the recommendations based on the AHA classification. So one is video laryngoscopy improves success. So it's a 1A recommendation. So there's no doubt today that, if you have a VL, use it during the first attempt at intubation because it increases first pass intubation success. Using a bougie and using a stylet was a 2A, 2B recommendation. Okay. And apneic oxygenation during intubation. So even routinely, we recommend that use, pre-oxygenate your patient and use a nasal cannula continue using a nasal cannula. Simple, cheap nasal cannula can be used. Even you don't have to use Thrive because that will prolong your safe apnea time from 8 minutes to at least 10 to 12 minutes. So in case your intubation is difficult, you can use a nasal cannula. So especially when there's an anticipated difficult airway, use a nasal cannula, give nasal oxygen during attempts at intubation. So IDA recommends that continue your peri-intubation oxygenation, even for your routine anesthetic, not necessarily only when you are in a difficult airway situation. Okay. So, and then based on expert consensus, what we have, and this was a statement, that neuromuscular blockage should be administered to improve mask ventilation when difficulty with mask ventilation is encountered in an adult patient. And we have 86% consensus on this. And, when I trained, I was taught, don't take away something that you cannot. We had a line like that, like you can't ventilate, then you don't give a muscle relaxant. But today, there's a paradigm shift in the way we are looking at neuromuscular blockade. And this is universal across the DAS guidelines, ASA guidelines, PUMA, everybody talks this. You give the muscle relaxant. especially if you're an inexperienced operator, because the chance that you will be able to mask ventilate the patient and the chance that you will be able to successfully intubate the patient is much higher if you give the neuromuscular blockade to the patient, right? And it's really a paradigm shift in the way we are talking, and it's a discussion and a whole lecture on its own. Laryngoscopy should be reattempted following the failed attempt. Now, this is important. The saturation more than 95. Everyone asks us, why did you set such a high threshold? Is 90 enough? So when you look at the oxygen dissociation curve, yes, you could use a lower saturation, but remember there's also a lag time with the pulse oximeter. So when you're seeing a saturation of 95, your saturation is also already much lower. And this is for safe airway management practices. We said that you should maintain a saturation of at least more than 95 before you go to the next attempt at laryngoscopy. And of course, in patients with a physiologically difficult airway, like critically ill patients, you may start only with a saturation of 80 and you may not be able to achieve this. For the attempts, we said 3 attempts at tracheal intubation. For supraglottic also, we said a maximum of 3 attempts. And for cricothyrotomy, as I mentioned, the earlier guidelines talked about any method, but we moved to surgical cricothyrotomy because there is good evidence to show that the success rate of surgical cricothyrotomy is superior to needle cricothyrotomy and should be preferred. And for this, we had 91% consensus. Okay, so this is the consensus for the Delphi. And I don't want to go through details. I'll go through the algorithm with you, and this is what the algorithm looks like. So let's go to the first part. Now, these are guidelines as we're talking about for management of unanticipated difficult airway in adults under general anesthesia. Okay, we are not talking about when your awake intubation fails or somebody somewhere who just stops breathing. We're not talking about that situation. We're talking about a patient in whom you are giving a general anesthetic and you encounter a difficult airway. Now, as I mentioned, we didn't start from a failed intubation. We said, you pre-oxygenate, you induce anesthesia, and you have some primary airway management plan. Now, that primary airway management plan can be a tube, it can be a supraglottic airway device, it can be a mask, it can be a simple nasal cannula. You can be using, just no oxygen, using TIVA. You can be using anything. The patient can be spontaneously breathing, or the patient can be under controlled mechanical ventilation. So, whatever type of anesthetic you are giving, whatever is your primary airway management plan. For example, I'm giving TIVA and I've just kept nasal cannula prongs on. Whatever is your plan. So we have not limited it to failed intubation or failed supraglottic or anything. Your primary anesthesia plan. Now, if that is successful, and when you say successful, you mean that ventilation is going fine, either spontaneous or controlled is going fine, and the saturation is maintained, not or, and the saturation. If you're ventilating fine, but the saturation is dropping, that's not acceptable, okay? So if that is okay, then you just continue as planned. Okay, so whatever your primary airway plan is, that is working. Now, if that is not hello, hello, I think there's some interruption. Okay, can you mute?
Hello, Dr. Reena. Can you mute? Can you mute, Reena?
Okay, thank you, Bhavesh. Yeah, so if your primary airway management, okay, as I mentioned, alone or in combination, you can use any device, spontaneous or controlled maintenance. If that is not successful, that means you're not able, ventilation is not successful, and you are not able to maintain saturation. Okay, and when we say successful, now this graphic is I'm very proud of this, and this is from this publication. It's a free download, and this is made by Puma. By the way, the Puma guidelines are not yet out, but we have put out a guideline for missed esophageal intubation. Now, this is really, really important. And I want to pause to tell you that when we all use capnography, we see one trace of capnography and we say, tube is in. But the guidance is for looking at 7 traces of consistent waveform capnography without any decline. So you can see this going up. Anything like this is acceptable, but not this. And this is really important in the context of a difficult airway management, because what happens is when you have a stormy intubation, a lot of air enters the stomach. When you do an esophageal intubation, accidental esophageal intubation, all that air starts coming out and you do see a capnography trace, but that will decline. So do not respond to 2 or 3 traces. So 7 traces of consistent waveform capnography with no decline is what we're looking at. And I'm very proud to say that IDA 2016 was the first guideline that talked about using consistent waveform capnography. Until then, ASA, DAS all said use capnography, but no guidelines specified that you should look at consistent waveform capnography. And this is what all guidelines have now reiterated. DAS has adopted this, IDA is, given this graphic, and so has the ASA, and saying that, and in your operating room, when your resident tells you, tube is in, when they see 2 traces, be very careful, look at 7, and then verbally confirm that the tube is in. Of course, you see the tube going under direct vision. That is one confirmation. And the second one is to look at waveform capnography. Now, if you are successful and everything is good, then you can go and have a coffee. Now, if that's not the case and you're not successful, and either the ventilation is not going fine or the patient is not maintaining saturation, then we say that is unsuccessful. So if that is the situation, then we have these 3 vertical bars. Most importantly, first thing, the first time you encounter any difficulty, call for help. Calling for help is really, really important, and maintain the depth of anesthesia as you're going through the process. And these are just vertical bars I want to highlight, because throughout the algorithm, we emphasize that if you've not called for help, call for help now. Maintain depth of anesthesia. You may have paralyzed the patient may be awake. So remember that, and deliver nasal oxygen, continue oxygen, whatever method you can use to give oxygen, right? So this is goes without saying that all the 3 you continue to deliver oxygen. Now, code D. Now, what is code D? Now, code D is a new proposal that we have. D stands for difficult airway. So this is a new thing that we have proposed, and we have proposed that when you call for help, don't say, call for help. And, this is a very specific call. Code D. D is for difficult airway. If someone says code D, I know that you need an expert. You need an airway management. You need someone who's, you need some specific tools, not like anyone coming and there's hypotension or bleeding or something, right? So it is a very specific thing for difficult airway management. And that is why we proposed code D. This was also something that was much appreciated internationally when I made the presentation. So coming back to the algorithm, now you're unsuccessful and then you enter the orange box, okay? So orange box has 3 lifelines. So irrespective of what anesthesia technique you use, you have 3 lifelines. Always remember, and if and this is pretty similar to the Vortex approach. I'll tell you the differences, that you have 3 lifelines. Always think I have 3 lifelines. I have a tube, I have a supraglottic airway device, I have a face mask. With these 3 lifelines, I can establish ventilation and oxygenation. So always think about interchanging. So these are the bidirectional arrows that I proposed during the ASA. And if you see the infographic, use similar bidirectional arrows for the IDA guidelines. So they are bidirectional because you're interchanging. So you consider interchanging between the devices. I started with supraglottic, I can go to mask, but I can also go to tube. I started with the tube, not necessarily I have to put a supraglottic. I can also mask ventilate the patient. So whatever you choose to do in your mind, remember when you have difficult airway, I have 3 lifelines. I need to interchange between these devices until I can establish successful ventilation and oxygenation. Okay. And in the meantime, what's important is when you're doing the second, attempt at whatever, or interchanging or whatever, it is really important that don't do the same thing again and again and again. And that tends to happen because of the cognitive overload that you have. So optimize your position. Ensure neuromuscular blockade. Okay, patient might have been given succinylcholine, patients come out, give muscle relaxant, your chance of success will be higher. Now change the tool, technique, or the operator. So you must have used a DL, use a VL now. Change your technique of putting a supraglottic airway, change it. Change the operator, get a senior person, get someone else to do it, okay? So always think, change the tool, change the technique, change the operator. Don't keep doing the same thing again and again and again. So these are things that you do, you must emphasize on between attempts at, while you're interchanging. Now, limit the device of attempts. This is really important. I told you the importance of this. Now, unlike the Vortex approach, and the Vortex approach talks about 3, 3, 3. 3 attempts at this, 3 attempts at this, 3 attempts at this. No, what we are saying is something different. We are saying 3 failed attempts, not 3 attempts. I'll tell you why. Because mask ventilation is non-invasive. How can I say I can only mask ventilate 3 times? When I'm intubating a patient desaturates, I cannot intubate, I mask ventilate, reoxygenate, again I try, again I reoxygenate. Mask ventilation is non-invasive. I can use mask ventilation as many times as I want to reoxygenate. So it's ridiculous to say that you have only 3 attempts at mask ventilation. Nevertheless, I have to have an exit plan from this box. I can't just go on and on and on mask ventilating and doing this, right? And this is the reason we said, for intubation, 3 attempts is okay, supraglottic 3 attempts is okay, but for ventilation, you need an exit plan. So that is why we said maximum 3 failed attempts. So if you fail mask ventilation 3 times, then you exit the box, okay? So this is the reason why IDA says not 3 attempts, but we say 3 failed attempts at intubation or supraglottic, or so it doesn't mean that you have to wait for 3 to happen. You can exit at any time, but maximum is 3 attempts. Don't go more than 3 attempts at intubation, 3 attempts at supraglottic, and 3 failed attempts at mask ventilation. And importantly, tracheal intubation, we emphasize that you Try the next attempt at intubation only if the saturation is more than or equal to 95. And I've told you about that. And Shilpa has also emphasized that important to keep track of time and saturation, because when all this happens, the things that we lose track of is really what is the time and what is the saturation. So this is the orange box. Whatever difficulty you have, 3 lifelines, keep interchanging till you achieve successful ventilation and you're able to oxygenate the patient. Now, if you're successful, that means you're able to ventilate the patient, and saturation comes up, like the case that I showed you in the beginning. So then it depends upon which device you've used. Okay, if you've used a tube, just confirm tracheal placement with the capnography. But if it was a face mask or if it is a supraglottic airway device, you have many options. So one is, I'm in a small place, I'm in a small nursing home, I don't want to do any masti, I don't want to do this case today, just awaken the patient. I'm able to ventilate the patient. It's not a wrong option. Okay, the surgeon may not call you again, but it's the safest option for that patient. Now, if you think it's a small breast surgery, I can do this on a supraglottic airway device, just continue the procedure with that if it's considered safe. Yeah, now if it is a laparotomy and you need a tube in, as I mentioned with the supraglottic airway device, you have to intubate through the supraglottic airway device using a bronchoscope if the expertise is available. And entry exchange catheter, as I mentioned, all this is there in the text. Please use the algorithm with the text because there's a lot of useful information there. So if you have the expertise available, but supposing I'm in a remote place somewhere up in the hills, I don't have a bronchoscope, I don't have anything, then the safest thing is to tell the surgeon to do a tracheostomy. I put in a supraglottic airway device, I can ventilate this patient, do a tracheostomy. Even that is a safer option than removing the tracheostomy and losing the patient, like what was happened for the case that I talked to you about. So once you have established ventilation by any of these 3 lifelines, you have this option. These are your options depending upon which type of device that you have put. Now, God forbid if that didn't happen and you're unable to ventilate with the 3 lifelines, that is the tracheal tube or the SG or the face mask, despite your best attempt, okay, 2-handed mask ventilation, using oropharyngeal airway, nasopharyngeal airway, whatever, despite your best attempt, you are not able to ventilate, then you declare complete ventilation failure. And I'll tell you why we use complete ventilation failure and not cacophona. And I'll tell you why we do that. And call for additional help. I already told you the importance of calling for additional help at this point. When everybody is shaking, everybody is tachycardic, and nobody's thinking straight, that additional help not only helps you, but thinks straight and tells you what to do. And you continue your efforts at mask ventilation, of course. Now, once you read complete ventilation failure, and I'll tell you why this terminology is appropriate, we suggest that you do an emergency surgical cricothyrotomy. And as I mentioned, we prefer surgical cricothyrotomy, but we don't say don't do needle or use commercial kits. You can use the other techniques if you're familiar with them, but prefer a surgical cricothyrotomy. And the reason being because all you need is a 6-number tube, and you need a bougie, and you need a 10-blade scalpel. And this is universally available anywhere in India. Remember, tracheostomy is not emergency airway management. Emergency airway management is cricothyrotomy. So you should be able to do a cricothyrotomy and not wait for a surgeon to come and do a tracheostomy. A lot of patients have been lost, a lot of hypoxic brain damage because anesthesiologists have waited for the surgeon to come and do a tracheostomy and not done a cricothyrotomy in the meantime. So this is really, really important. Now I'll talk to you about this term complete ventilation failure and why this term is appropriate. So when you have an airway that has failed, despite your best attempts, your 3 lifelines, you're not able to ventilate the patient. Okay, failed tracheal intubation, failed supraglottic, failed mask ventilation. Your saturation is 100 and it will plummet down very soon to 0, as you know, cardiac arrest, hypoxic brain injury, death, as we saw with that patient. Now, there are 3 different steps at which you can intervene to do a cricothyrotomy. Now, we at IDA say intervene at the first step when you fail to ventilate the lungs. We say declare complete ventilation failure. Complete ventilation failure because all the 3 techniques have failed. And we say this is the time to intervene when the saturation is still 100%. And the reason being is because ventilation failure precedes oxygenation failure. So when I cannot ventilate the patient, I know the patient will desaturate. I know this is unnatural. Now, how long the patient will take to desaturate depends upon, did I pre-oxygenate well? Am I using Thrive? What is the physiological reserves of the patient? But what is inevitable is ventilation failure precedes oxygenation failure. And we believe that that should be your cue to start. Because I don't want to start doing a procedure I've never done in my life for the first time when the saturation tone is going down, 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 down. I want to do it when I fail ventilation and the saturation is still preferred. Now, failure to oxygenate. Okay, this is where DAS says failed oxygenation. But again, failure to oxygenate. So we did a nationwide survey and asked people, what do you mean by failed oxygenation? To some people, it meant failed ventilation. To some people, it meant saturation falling. So failed oxygenation means different things to different people. So we have to be very careful, because it can lead to a wrong understanding of what failed oxygenation is. And especially in the era of apneic oxygenation, when we're using Thrive, I can continue to keep the saturation at 100 for maybe 30 minutes, right? But what is inevitable is that the moment I'm unable to ventilate, that saturation will fall. So it is inevitable. So better to do the cryotherotomy when the saturation is high, and definitely not when hypoxia is set in, when you declare, failure to oxygenate. And this is the reason we feel that complete ventilation failure is a safer trigger to do a cryotherotomy rather than wait for oxygenation failure. And we believe that this should be your trigger to use it. So we don't use mnemonics anymore. The Puma has moved away from mnemonics like Kaiko and Phona. Kaiko, when you say Kaiko, I don't know, in Mumbai, it is like, why should I do it? Kaiko karu. It's not very well understood universally. And if you look at what is dominant in the literature is terms like Kaiko and Phona, but in clinical practice, what is dominant is emergency cryotherotomy. So we use the term emergency cryotherotomy because when you say emergency cryotherotomy, you give a sense of emergency. Because it's like cardiac arrest. You know that everybody understands as an emergency. And when you say cryotherotomy, it is a cricothyroid membrane that you're targeting, and so you're already focusing on the anatomical side rather than say Phona. When you say Phona, front of neck access. So I've never understood, and I often ask this with my DAS friends at DAS, that why do you say front? Do you know of any back of neck procedure that you would do during airway management? I don't know, maybe the only procedure I know is cervical epidural or something. So why front? And neck, when you say neck access, there are many structures in the neck. Are you talking about IJAB? Are you talking about the carotid? What structure are you talking about? Are you talking about the trachea? Are you talking about the cricothyroid membrane? So when you say neck access, there are a lot of things that you could access. So when you say emergency cricothyrotomy, there's an emergent nature of the procedure, and you're talking cricothyrotomy, so there's a specific target. And there are different ways of doing a surgical cryotherotomy. Now, the reason why surgical cryotherotomy was discouraged, because we are anesthesiologists. We are not confident at cutting and doing dissection. We are not surgeons. You tell an anesthesiologist to put a needle, do Seldinger, do guide wire, do dilatation, they will do it very, very easily. But you tell an anesthetist, come on, start cutting and do dissection. We are not surgeons, and we're not very comfortable with doing that. And that is the reason why, even though surgical cryotherotomy needs simple tools like a knife and just a bougie and a scalpel and a bougie, your hands are shaking. You're so scared. You'll never make that cut. It's really, really difficult. And that is the reason we moved away from making that big incision and all that to a simple stab, twist, bougie tube. And this is described very simply in all our workshops. We teach this on cadavers. We teach this on cadavers. We also teach this on animal models. And I remember in the workshop we had in Thana also, we taught this technique. I remember a picture was there. So a simple stab, because stab is easier to do than, making a cut. So you make a horizontal incision, horizontally you do that, and then you twist the scalpel, the blade facing the caudal side, move it towards your side, and then with the dominant hand, you put the bougie in at least 7 to 10 centimeters, and then you railroad the tube over. But details of this procedure are given in the algorithm. Okay. And so it's really important that and if you can't do this technique, even using a needle or using any of the, like the Cook Milk or any commercial kit, though the success rates are less, if you're familiar with it, use whatever you're familiar with. But we encourage that you should teach this across, because, it's universally available in India, especially in a resource limited setting, and it is really good to use. Now, post-procedure plan is all of us have encountered some some unanticipated difficult airway, and we've been able to save the patient and everything's fine. But we forget that you should be careful. What is a further airway management plan? I did a cricothyrotomy. Should I do a tracheostomy? You can't continue with the cricothyroid, the airway in the cricothyroid membrane. Treat edema if suspected. Sometimes the edema can worsen. Monitor for complications. This patient might have bleeding complications, other complications, the airway might deteriorate. So never leave a patient who had an anticipated difficult airway. And most importantly, counsel the patient and the family. This is better sometimes than documentation, because they may not produce the right documents at the right time. So tell the patient, you had a difficult airway, or tell the family. Anytime you go for anesthesia, tell the anesthesia, because the best for pre-op assessment of a difficult airway is a previous history of a difficult airway. So, this is the best thing that you can tell the patient, and that can save some other anesthesiologists. So make sure that you do this. So I'll leave you here with the what the adult guidelines look at. So just to, highlight what is new in the IDA guidelines, very robust methodology, and I'm really proud of it. It is not 10 people sitting together and say, chalo, ye karna chahiye, wo karna chahiye, and let's tell the world how to manage airway. No, no, that's not the way. Code D, and we think Code D is very specific. We've started using it in our hospitals. We say Code D. When you say Code D, people know. Even the ward boy mama knows, Code D means airway nahi, difficult airway. Now get, an airway expert or get somebody who will be able to help us with a difficult airway. Now, the guidance is not only for a failed intubation, but a failed SGA, failed mass ventilation, or any other strategy used for primary airway management under general anesthesia. We've moved away from that linear approach to a circular approach, very similar to Vortex, because Vortex makes a lot of sense. But remember, it is not 3 attempts at mass ventilation, but 3 failed attempts at any of the 3 lifelines that we have. And this time when we made pediatric and obstetric, we had collaboration with both the airway societies. Initially, when it was made, it was only IDA, but this was a guideline in collaboration with the National Pediatric Society and also the Obstetric Airway Societies. We had representation from them, and they were very much part of making the guidelines. So the emphasis was already there on what we call per oxygenation, that is peri-intubation oxygenation, waveform capnography, and complete ventilation failure. These were all emphasized in our previous guidelines. Complete ventilation failure as a trigger for cryotherotomy. We have further emphasized this in the current guidelines. And the guidelines, this is only adult, but you have pediatric, obstetric, and extubation. And all this is published in the December issue of the Indian Journal of Anesthesia. And you can scan the QR code, and all of them are a free guideline. And the ICU guideline is going to be revised this year. We didn't do it in conjunction. We just did this separately. So with that, I thank you very much for your attention. I'm sorry I've taken 4 minutes extra. I'll stop share, and I'm happy to take questions.
Thank you, Sheila. I think you have done an excellent presentation. I think it was told in a very scientific way that why each step was included. I think everybody must have might have got enlightened by why the procedures and why these guidelines were formed and why what we had to do because of the evidence-based medicine. Can we take some questions, Yatin? 2, 3?
Yes, yes.
Yeah, so this is from my side. When in a unanticipated difficult intubation, we call for help at the first attempt, okay? Failed attempt. Why not to call that additional help at that first attempt, and why not at ventilation failure? So any
Yeah,
specific reason
good
for that?
question. So remember that whenever you call the faster, whenever you have the first difficulty, the faster you call for help, the faster help will arrive. And like in cardiac arrest, you'll be help. But this specific calling, as I mentioned, was not as an additional hand. Earlier, you need an additional hand. Na? You want to do some procedure, you want to do something, you want someone else to help you. But this, as I mentioned, is to overcome the human factor. So you're about to do a cryotherotomy. You know now the 3 techniques have failed, and that's when they call for additional help to overcome the human factors. So initially, when you just fail, that doesn't come into play because I've just failed my intubation, but I'm not thinking that my supraglottic and my mass ventilation are failing. That is when you know, oh my God, now this is going to hit the roof. I am failing in all 3. I'm reaching complete ventilation failure. And this is the situation you know that now, and every anesthesiologist know this because, your third lifeline is also going now, now this is going to be, that's the situation you say, call one more person, call another, So it's really for the human factors which don't arise in the initial stage.
And what is some questions about needle cricothyroid?
Yes. Okay. So we haven't said don't do it, but there are some studies which show the success of surgical cricothyrotomy is higher. But very interesting, even in the National Audit Project, those cricothyrotomies, were not done by anesthesiologists. They were done by ENT surgeons. So it's very interesting. The success is higher, but it was done by ENT surgeons. So, I still feel that when your hands are really trembling, it is very difficult for us to cut. And, unless you're someone who's routinely doing tracheostomies or has done percutaneous tracheostomies and is used to cutting the neck, it's difficult to cut the neck. And that is why we've given this stab because, the stab is easier than cutting and dissecting and doing blunt dissection for the first time. So, this is a technique, but we have said you could use the needle. But the thing with the needle is the needle kinks. We use a cannula, like a 14 gauge cannula is used, often kinks. VBM has a non-kinkable kind of but the other thing that anesthesiologists think is, I have a needle, so I'll do needle cricothyrotomy. You need pressure regulated chest ventilation. Just putting a needle in is of no use. How are you going to ventilate the patient? And then people talk about using ambu bag, and you cannot ventilate like that. So you need pressure regulated jet ventilation. If you have pressure regulated jet ventilation and you are able to do it, then go ahead. If you are familiar with the technique, use that. But what we say is evidence-wise today, like Das had already said, before, the surgical cricothyrotomy should be the preferred technique. And in India, we should promote this. We should promote this because it's very easy with just a scalpel, 10 blade, and just a 6-number tube and a bougie, universally available. So this is not something that you can learn just working with Bhavesh or something in the operating room. You need to practice this on mannequins. So if there's one workshop that all of us, and there's also a fade. After 9 months to 1 year, you forget the technique, okay? So this is one workshop that everybody should do, repeatedly, or do it on, or have a kind of model. And this is where I really like the things about the DAS guidelines is that they've given a huge emphasis on, teaching and training, because guidelines, if they're just published, they remain as a publication. How are you going to disseminate it? What is your plan for dissemination? That's really important. So I think these little things like bites and all this that Shilpa talked about is really important, because we need to, if you ask half the people or more than half the anesthesiologists in our country, what will you do if you can't intubate, you can't, they will say, surgeon ko bulao, tracheostomy karo. Really, I'm telling you, this is what is the reality. Or even if they don't say it, that's what they do, because they really panic and they're not able to do anything further. So, how many people are trained to do a cricothyrotomy? How many people will actually do it when the situation arises? Of course, the best cricothyrotomy is the one that you will never do. You don't have to do, right? So we should try to prevent that situation. But God forbid if that occurs, all of us should be trained to do a surgical cricothyrotomy.
Shilpa, one question for you. If such thing happens in a pregnant lady and you had to intubate by using scoline or rocuronium, what would be the effect of Sugamadex if you want to reverse the patient immediately on the baby as well as on the mother?
Yeah, on the mother, natural nothing, because we are using it in and out for an adult patient. For baby, I don't think the effects have yet been proven. And of course, it will have effect on the baby because it will cross the placenta. But I think mother first. So we have to save the mother. And
So,
baby,
so it would mean that still use succinylcholine as a first drug of choice, something even if you have a rocuronium with you?
yes. I still use, because I feel that rocuronium using 1.2 grams, and if I get a difficult intubation, I have to keep my 5 vials of Sugamadex ready. I have to have someone diluting it, loading it, and I'm giving it. So and I use 25 milligram of succinylcholine. With all those high risk of malignant hyperthermia, I know it's time for me to shift. One day I will try shifting, but I still use succinylcholine.
So if I may make I don't do any obstetrics, but I would agree with Shilpa on that. People are really scared to use suxamethonium. I've used a lot of suxamethonium, and really a lot of the complications that people talk about are more theoretical. But having said that, even when you use rocuronium for an RSI, which you would do, you have to use higher doses. You have to use at least 1.2 milligram per kg. People don't use that dose, because if you don't use at least 1.2 milligram per kg, you will not get intubating conditions in 60 seconds. You will not get those conditions. So why do you do an RSI? You want to shorten the time and you want to prevent aspiration. Now, if your intubating conditions are going to come in 90 seconds, you're increasing the risk of the aspiration. So you have to use a higher dose. And again, safety of the mother first is paramount. So in an emergency situation, and how much Sugamendex are you giving? You're talking about 16 milligram per kg. So that's a huge dose. And, people think, oh, I have Sugamendex and that's the panacea, but it may not always work to the effect that you want it to work. So, there are a lot of things in between that come. So it is not like the magic bullet and then, you say, okay, I have Sugamendex, so everything's going to be taken care of. So I
Sheila,
would still consider using suxamethonium in certain cases, specific cases.
Sheila, once again for you, in that flow chart, in the orange one,
Originals, yeah.
the reversible, we told that when the patient started breathing and the saturation is still falling down and we have failed attempts, we are told ki deepen the plane, correct? Deepen, give muscle relaxant. Now, earlier it was like when you cannot intubate, when you cannot, saturation is going down, and then give a scoline and then do a cricothyrotomy, correct? That was the way.
Yeah.
So, is it not wise that we don't paralyze the patient more if patient is coming out and let the patient come out of that during the first time?
So yeah, so you're absolutely right. So this is the big paradigm shift in airway management, and it's universal across all guidelines have adopted this. And we actually make things more difficult for us by giving thoda sa ye, and this is not actually anesthesiologists. I work in ICU, so a lot of physicians are there. They're very worried about giving drugs. They give thoda fentanyl, they give thoda sa propofol, they don't give muscle relaxant, they try to intubate. They have least experience with intubation, and they make the worst condition for themselves for intubation. So the thing is that you will be able to successfully mask ventilate. And in the era with the video line, you will be able to, you're making things difficult. And as you go down in the orange box, what happens is, what is your option? What will you do? The patient is desaturating. If you give muscle relaxant, there is a chance you'll be able to mass ventilate this patient. But here you're not able to mass ventilate. You're not able to put a epiglottic. You're not. And now you're going to do the procedure you're doing for the first time in your life. Are you going to be able to do it in a moving patient? The best success will happen, and you'll be able to palpate you'll get the right anatomy and everything if the patient is still and not moving. So the that fear of not giving has actually cost more lives than giving the muscle relaxant at that, because you're with your back against the wall. You've burnt all your bridges. So now give the muscle. So we say ensure neuromuscular blockade, especially if you're given saxamethonium. But if rockinonium is given and continues, so we say make sure that there is neuromuscular blockade is there before you proceed for the cricothyrotomy.
Excellent. I think we will go on to the next session. Then we will take, if you have time, we will take few more questions later. Sanjana, can you
Yes, sir.
carry forward it?
Sure, sir. Thank you. Can you hear me, sir?
Yeah.
Yeah, okay. Good evening, everyone. In the last session of our webinar tonight, we deal with one of the most common yet gray areas in the life of an anesthesiologist, that is the preoperative investigations. To answer our questions pertaining to not just what to order, but why, when, and for whom, and its medico-legal implications, we have with us Dr. Yatin Khairnar. Dr. Khairnar is one of the most dynamic personalities, currently serving as the honorary secretary of ISA Thane. Sir is a senior consultant at Kaushalya Medical Foundation Thane, Bhanushali Center for Lung Surgeries Thane, and Criticare Asia Group of Hospitals, Mumbai. Sir has been a faculty at various CMEs and state conferences. Sir has been a faculty at various CMEs and state conferences, and his special interests include thoracic anesthesia, hypic and onco anesthesia, pediatric and neonatal anesthesia. We are pleased to have him with us today. Over to you, sir.
Thank you, Sanjana, for a very kind introduction. I'll just share my screen.
Yes.
Is my screen visible?
No, sir. Can't see your screen. I think you'll have to double click. Yeah. Now I can see it.
Yeah. So once again, very good evening all. Today we are going to discuss about something which we do daily but rarely question. So that is preoperative investigations. And this session is for us to know how much is too much. So objectives of today's session, am I audible?
Yes, sir, you are.
So the objectives of today's session are to understand the specific investigation protocols and to apply the evidence-based guidelines in our clinical practice and to avoid unnecessary investigations and reduce the cost and to improve the perioperative patient's safety and the outcomes. So why this topic matters? So over investigation increases the cost, causes delay in the surgery, and with over investigation there are also false positive, which also further delays the procedure. While at the same time, under investigation or under testing of the patient can miss the diagnosis, and that can increase the perioperative risk. So we need rational and evidence-based decision making. So many centers in India still do a routine panel, and we need some guidelines so that this can all routine panel syndrome can be avoided. So what the core principle behind this is, the pre-operative investigations are not routine. They must be done only when clinically indicated. So, how to proceed? How do we know how much is too much and how much is enough? So, there is a decision framework. So, we'll go step by step with this. So, preoperative evaluation is the most important cornerstone and pillar of this decision framework. So, detailed history taking and evaluation tells us maximum things about the patient. After that, we do classify patient as per the ASA classification, whether patient is ASA grade 1 or 2 or 3. And after this, the surgical risk is assessed depending upon the type of surgery, whether it is minor, intermediate, or major. Then we order the investigation. So these investigations which we'll order will be targeted towards the specific comorbidity of the patient. So ASA classification, as we all know, ASA grade 1 being healthy and ASA grade 4 being patient with life-threatening disease. And surgical risk stratification, as I said, minor surgery to major surgery. So these four are very important pillars which will help us diagnose the patient and with the minimum investigations. So there is something called as NICE concept. So National Institute of Health Excellence, Health Care and Excellence has this NG45 criteria, which has green boxes for where we have to do the investigations, yellow boxes where it is like you can consider the investigations, and red which says that it is not routinely indicated. So let's go investigation wise. So hemoglobin. So as per this NICE criteria, NG45, globally accepted criteria are NICE NG45 criteria and ASA criteria. ASA criteria focuses on history and evaluation of the patient. And if the patient is symptomatic, then only do the further investigations. While NICE criteria is more structured and it is based on the AS status of the patient and patients and the type of surgery. So hemoglobin. For the hemoglobin, it is not routinely done in every patient. I would say it is not necessary to do it in every patient. ASA grade 1 patient, ASA grade 1 patient for minor and major surgery, minor and intermediate surgery, actually we need not do the hemoglobin, because on preoperative evaluation like history and examination itself will tell you whether the patient is anemic or not. So for minor intermediate surgery, hemoglobin is not must. For ASA grade 2 patients, intermediate surgery you may consider it, and for major it is required. Same way, ECG. ECG is not to be not required for every patient. Patient more than 40 or 45 years of age, or the patient with any history and symptoms symptoms of any cardiac element. Then only you do the ECG. So as a grade 1 patient, minor and intermediate surgery, as a grade 2 patient, minor surgery, you don't need to do the ECG. Intermediate surgery, as a grade 2, you might consider, but for as a grade 3 and 4, it is to be targeted based on the history and evaluation of the patient. Chest X-ray, chest X-ray is not actually indicated in almost all cases because it has low yield, and doing an X-ray does not change the what we say. It does not change the perioperative outcome. So investigation should be targeted. Even renal function test, it should not be done routinely for minor surgeries and for intermediate surgery for grade 1, ASA grade 1 patients, we need not do it. And minor surgery in ASA grade 2 patients, we should not do it. Intermediate surgery for ASA grade 2, we think, and for ASA grade 3, it is to be target based. Liver function test, it is not a screening test. So we should not do liver function test in every patient. It is recommended only when indicated. When you suspect any liver disease, alcohol use, or jaundice, that is all you will come to know on history and examination. So whenever you suspect all these things, then only liver function test has to be done. Then coming to blood sugar, it is to be done when there is a history of diabetes, and there are any other risk factors which are involved, then only you do the blood sugar. Then let's come the age wise. So in pediatric patients, most of the pediatric patients are very healthy, so you need not do any investigations. I would say not a single investigation is required for minor and intermediate surgeries. But when to do the investigations? So if the history and examination is suggestive of some congenital animal an anomaly or some chronic disease, then only you do the testing. So for minor surgeries in pediatrics, no testing is required. For adults, ASA grade 1 and 2, we require minimal testing. Or for minor and intermediate surgery, no testing. So this approach has to be changed, and I don't know when it will every center will start using this nice criteria every day in day to day practice. I will come back to why we are not following it at the end of the session. So in geriatric patients, so what we see always that if the patient is more than 60-year old, then we always consider that patient is very, patient is going to be high risk, because he will be having some comorbidities, or whether he has or not, we suspect that he must be having something which we are not able to pick up. So I would say proper history and examination will tell most of the things about that patient. And age is not the criteria, because there is the physiological age is the birth, actual years of the age, but there is something called as chronological age, and that all depends, on the functional health of the functional status of the patient, depends on the lifestyle of the patient and genetics and cellular health of the patients. Many geriatric patients who are like, even 80 years old, they don't have any comorbidities. So in those patients, you need not do each and every investigations. If and there is something called as so functional status index, and it is just a sequence, just a questionnaire, and a self assessment of the, and patient can just answer that, and you can come to know how frail is the patient. Then again, coming to comorbidities, as I said, if the patient they have comorbidities, definitely the testing should be done as per the disease specificity. Now coming back to for emergency surgery. For emergency surgery, we need not do all the tests. We should not delay. We should not delay the surgery for the investigations. Perform essential tests and simultaneously stabilize the patient. When to postpone the surgery? When patient is not well optimized, when patient has some uncontrolled, or there is severe metabolic derangement. So then you have to optimize the patient and then only do the case. So one has to remember this clinical algorithm. So history and examination, that 90% things are, you can tell us 90% things you comes to know by history and examination, which helps us decide whether the patient is ASA grade 1, 2 or 3. And then surgical risk stratification based on type of surgery, whether it is minor, intermediate and major, and that whole is applied at the in the nice criteria. So there is a table, I will share it, and then do the targeted investigations only. So I want to ask you all one thing. If the patient is young and is a grade 1 for a minor surgery, will you do any investigations? So if Sanjana, will you help me here?
Yes, sir. Yes, sir. Sir, I think most of us are concerned with the medical legal implications
That
if
I'm
we do
going to
not
come back.
do
Yeah.
the
That
test.
will be explained after this. But
So
whatever
for
I have
this
explained till
particular
now,
case, sir, yes, sir, for the young ASA1 young male that you said, almost
yeah.
we have
So
got
the
responses
nice,
saying CBC.
So the nice criteria says ASA grade 1 patient, young patient, you need not do any single investigation. So again, a second question I'll ask: a patient with age of 60 and with the history of CKD, what investigation you will want to do? Diabetic patient, for example, a diabetic patient, 60-year-old, elderly. What investigations will you will all of us do? Routine panels, all the routine panels. Am I audible?
Uh, So your net is cracking up actually.
Oh, I don't know. I mean, am I audible now?
Yes.
Or
Yes, sir, you are audible now. And we have got a response for your second case saying
Mhm.
CBC, RFT, ECG, 2D echo, HbA1c, electrolytes as well.
Okay. So diabetic patients definitely blood sugar and HbA1c will do, and diabetic patients are prone to CKD. I have already said that, but we will do RFT and ECG.
Yeah.
So then coming to what mistakes we do. So we order routine panels for each and every patient. So actually investigations are to be ordered based on your clinical judgment. So what we feel is that if the patient, if you investigated the patient thoroughly, that means you are safe, and everything gets caught on the investigations. I like to uh, 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 talk about one case, just about the this thing, one orthopedic case. They did see the MRI, and the patient was consulted, and the patient underwent lumbar discectomy, and this thing was, they had fixed the spine, and post operatively patient had paralysis. So why? So they did miss the proper history taking and evaluation. So even MRI was showing disc pathology in lumbar region. What patient's main thing was, patient had severe cervical disc prolapse, and which was missed out. So you cannot rely completely and totally on investigations. Your clinical judgment is completely and for most important. So history taking and proper examination of the patient is must. So this tells us, even if your investigation, even if your all the investigations are normal, that doesn't mean that patient is fit. So we have to understand this thing. All investigations are normal, that means patient is fit. No, you have to properly, thoroughly evaluate the patient, do proper history taking, see for the symptoms, and examine the patient. That will guide us whether patient is fit or not. So what are the do's? Individualize the patient care, follow evidence-based guidelines, and what not to do is don't order all the routine panels every time, and don't ignore the clinical findings. So what about viral markers? I would like answer from the audience.
Uh, Necessary, sir. So most of us are replying that viral markers are must.
Okay. So what we are doing is, are we doing viral markers for the patient or for us? Is there any reply, Sanjana?
Not yet, sir. Both, for both the patient as well as the doctor.
So most of us, I would say, do viral markers for us, I would say. So why viral markers are not routinely needed? Because it requires actually, without patient consent, you cannot do viral markers. This is actual thing which no one is following in India. But why it is not recommended routinely? Hello, hello, am I audible?
So there's a disturbance here. Um,
So why viral markers? I am saying it is not must. I will say one thing. If we say that viral markers is positive or negative, if the viral markers are negative, is it so that patient is 100% negative? Patient might be in middle period, and we will be having a safe, a false sense of security that patient is negative. So this can happen. So what important is not the viral status of the patient. Important is universal precautions. You should consider each and every patient to be infectious, and do and follow the universal precautions. So wearing gloves, wearing protective eye equipments, and safe needle handling, and following proper sterilization protocol. That is must. That is important, not the viral markers. But most of us are doing, routinely viral markers. So medical legally, I mean, the consent has to be taken. of the patient, which no one does. So, uh, what about medical legal? Is there any reply? You all are
No, no,
concerned
sir, not yet.
medical. So, will we be held responsible if we under investigate the patient? I want a reply from participants.
Um,
Will we be held responsible if we have under tested the patient? And who decides that we have under tested the patient?
so we are getting replies as yes, that we will be held responsible for under
So
investigating the
most are
patient.
yes, but
That's the reality. So,
no, that is not the reality. We are having, this is the myth that more test is more safety, and routine investigations prevent us from litigation. So what court assesses is the standard of care. If it doesn't mean that all investigations you are have done and something happens to the patient and that you will not be held responsible. Court don't see what you have, whether how much you have tested the patient. So there is something called as Bolam principle and Bolito principle. So what is Bolam principle? A doctor's actions are judged against the uh, I would say a responsible body uh, of competent anesthesiologists, what they would do. So doctor is not negligent if doctor follows the uh, evidence-based guidelines. So this is what court accepts. And NICE criteria and NG45 and ASA criterias, these are the guidelines which we follow. So investigation should, if you have done investigations based on clinical judgment, you will never be caught or not held negligent or responsible for whatsoever happen. Only thing is that your decision should be justifiable. So there is something called as this Bolam principle is based on the standard of care. So court sees whether you have thoroughly assessed the patient, whether you have done a proper history examination of the patient, whether you have graded the patient, whether patient what grade, what ASA grade the patient was, what was the surgery, that means surgical risk stratification. So these three important pillars which I said, history, examination, and it has to be properly documented. So this fourth one, so important is all these four, and properly documentation is very important. What is Bolito principle is, what so this question comes to should come to your mind if I'm talking about Bolam principle. What the medically accepted guidelines, if you are following, or you are helped, you are judged against what a responsible body of anesthesiologists would do. But what those doctors differ, will you be held responsible? The answer is no. There is something called a Bolitho principle. So what is this principle is about? So it is logical principle. So it is like, your every decision should be justifiable, you know so whatsoever. For example, you have tested the patient. I'll just give an example. You have tested the patient, and patient is ASA grade 1. So what documentation, like when you do document, you note proper history, you note proper examination, whatever you have done, grade the patient as per the ASA, and surgically stratify the what surgery it is, and then you have to document that all. For example, no clinical indication for LFT, ECG, and chest X-ray. Patient is ASA grade 1, and this protects you more than the extra test. Proper informed consent, then risk explained to the patient, and patient optimized as per the clinical judgment. If this all is included in your paper, so court is not going to hold you responsible if you have done whether why you did not do the LFT or why didn't you do the ECG, because patient clinically assessed patient thoroughly is ASA grade 1. So this is what we all should know. So this Bolam test I have explained, then Bolito principle. So there are famous cases which have happened, Jacob Matthew versus state of Punjab. This was happened in, I guess, 1997. So what this happened was, the important point here is that negligence requires gross deviation from the standard care. So what court sees is what standard care you have provided. If you have worked as per the guidelines, and they don't want you to be expert, they just want a proper standard care to the patient, what any ordinary anesthesiologist or any ordinary doctor would do. They don't want a perfect skilled things. They want just what a ordinary doctor would do for that patient, whether you have done or that or not. And logically, you should be, your decisions whatever you have taken should be logically justifiable and defensible. So that is what protect us from the litigation, and not just doing each and every test. So this is very important, which we should know. In this Jacob Matthew case, what was happened, the patient was admitted under a doctor, and uh, unavailability of the oxygen cylinder, the patient died, who was the 2-year-old patient with croup. And no, there was some patient, and he died because of lack of cylinder. So uh, doctor was litigated for this, and the judgment came from the court that doctor should not be held responsible for this, because it is an administrative problems. So these are the things. There are this Bolitho principle as well as Bolam principle does protect us from the litigation. And judge, as I said before, I am stressing it again, court sees how well you have assessed the patient history, examination, how well you have documented that, and how you have graded, the, so that all part is there. Court will never held you responsible for minimum test. If it is a major surgery and you have not done hemoglobin, then that is wrong. But for minor surgeries, for intermediate surgeries, for ASA grade 1 patient, it is not needed. So what my take home message with all these is that investigation should be selective. Clinical judgment is the key. Documentation protects us. Test smart, not more. So I'll just show this nice table, and it is followed globally. So nice NG45 table. Now here the image is like, I've animated it, so everything is not green and it is just black, but normally it shows red. So if you see this table, maximum places you will see red, 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 red. Red means no. So if you see ASA grade 1 patient, hemoglobin, ECG, renal function test, chest X-ray, no, it is not needed for minor surgeries. For intermediate surgery, no. For major surgeries, yeah, hemoglobin, ECG, kidney function test, you consider. But even chest X-ray, only if indicated. How? By history and examination. You see, as a grade 2 patient, the table, hemoglobin, ECG for minor surgery not needed. Intermediate surgery, yes, you do consider if there is a history or examination suggestive of some problem. Major cases, yes, you should do. For grade 3 and 4, there is no criteria by nice. You have to do focused investigation. This is specific investigations. Patient has comorbidities such as hypertension and diabetes, then it is your way of assessing the patient. Like, for diabetic patient, you will do blood sugar, you will do kidney function test, and if the patient has cardiac problems like hypertension, so you will do all these things. Even electrolytes you will do to avoid dysrhythmias, or you want to see how how well the potassium serum potassium is. So that is all. The investigations are focused based on the comorbidities of the patient. So what I want to take, I want you to summarize is from this lecture is this master table. So this tells us what investigation and to be done and when to do. So viral markers you will do only in high risk patients, like if the patient has a history of the sexual exposure or use of IV drugs, and history of any liver disease before. So that way you will stress upon doing the viral markers. So same way, these all investigations are there. So
Sir, we have a comment by Aparna, Dr. Aparna, ma'am.
yeah,
Ma'am says, for Indian context, one needs to consider ISA guidelines of 2022 for Indian scenario and the
no. So our India, our ISA guidelines are mixture of you know, Indian guidelines are mix of ISA, ICMR, and even they have strong influence of, NICE NG45 and ASA guidelines. ASA guidelines are worldwide, globally accepted. What ASA guidelines says that history and clinical examination is more important. Do investigate the patient who are symptomatic. In non asymptomatic patient, investigations are not needed for minor and intermediate surgery. And this Bolito Jacob, this Jacob Matthew versus versus State of Punjab. This is the Indian case, and there are many cases which people have won because of this Bolam and Bolito principle here in India.
And sir, what about when patients themselves want to get investigated before any
Yeah,
surgery?
if the
Will you
patient wants if the patient themselves wants to get investigated, you have to explain the patient that clinically whether it is indicated or not. Ultimate decision lies with the anesthesiologist, but you have to tell him that, see, if you over investigate the patient, there is fear, there is not only cost, there is fear also, anxiety, and delay in the surgery. So you have to explain everything to the patient. If the patient wants to get investigated, but for what purpose, what is the mentality of that patient that time, or was he afraid of something? So you have to look into everything, but ultimate clinical judgment should be from the patient, from the anesthesiologist himself.
So there's a question from my end. We usually, like, this is a very everyday scenario that the surgeons do not agree with the list of preoperative investigations that we give to them. So how can we deal with it?
So sorry, I beg your pardon.
So the surgeons are usually not very comfortable with the list of pre-op
Then you have
investigations
to
that we give.
correct,
How do
correct.
we convince them?
So that way, you have to show the evidence to the surgeon. You have to discuss this evidence with the surgeon, and discuss these guidelines with the surgeon, and tell them. So there are many surgeons you must have seen. They just want to operate. It's the other way here in India. They just want to cut. How? That's our look after. How the patient to make fit, that is anesthesiologist, that has to be seen by anesthesiologist. Many people wants to do, it's exactly opposite in India. Even we people tell them that, wait, let the patient get optimized, at least for major surgeries. So these all things, these investigations, preoperative investigation, this is mostly for, say, grade 1 and 2 patients. 3 and 4, definitely, the for whatever you have to consider, you have to see history. And we people are, like most of the young anesthesiologists, they are forgetting this thing, that history and clinical examination is for most important. 90% of the things are decided by the history and clinical examination, but not by investigations. So that has to be understood. What we say is that, have you done the investigation, send me the investigations, I'll see the investigation. Investigations are normal, patient is normal. No, you have to go and see the patient, which is practically difficult in India, as we are all, private anesthesiologists. I know, we get a call from a surgeon, he says that, I want to operate tomorrow, how you are placed tomorrow. And then we just see our schedule, and just we, plan things accordingly. We just ask the RMO to send the report. See, this is happening, so this is not going to change immediately by tomorrow. And I'm not saying I am following everything what I've said. So there has to be, and we have to start applying these things slowly, slowly, slowly.
Yatin, in post-COVID scenario, patients, do you investigate, suppose if for intermediate, major, or supramissory, anything different than what we have done?
Yeah, the post-COVID patients, I mean, the COVID has affected many of us, and there are a lot of things, whether the Indian government, or whether foreign officials, or whether uh, vaccine makers accept it or not. We all know that, no, not only the COVID, but not only the COVID, but the COVID shield has been the problem in many of the patients. It has caused, myocarditis, and it has caused, this thrombosis event in many patients. But now when COVID has gone, it is long time. So these patients, if you properly take the history and examination of the patient, you will come to know that whether the patient has, for example, the patient is having breathlessness on exertion, so you'll investigate the patient more. You will go for PFT, or you might ask for a, on examination, if on auscultation you feel that air entry is not equal, or there are some craves or some foreign sounds, then you will, definitely one should then further investigate the patient. But only the patient had COVID, so I will do all these tests? No, I will properly see the history and examination, then I'll decide.
See, See, what I have seen in the patients is that the patients who had a COVID but were on NIV or on a ventilator and they have come out of that, what I have seen is that those patients, when we earlier post-COVID, we used to advise them pro-BNP and D-dimer, which was a compulsory test during the post procedures and all. But what I have seen at this since last 2-3 years also, that when I am advising in certain specific types of patients, they do have a 3 times more the D-dimer levels. The pro-BNP levels are very high, even though the echo is normal. Okay, and I have seen 2-3 patients who have resulted in a morbid mortality, and we have been able to even prevent a mortality by doing these tests. Who were patient basically on ventilator or an NIV for a pretty long time, who have received an remdesivir or tocilizumab when that were there. So I think this test, pro-BNP and D-dimer, does have a role significantly in a supramajor carcinoma and certain types of patients who have
Yes,
undergone,
I
who have
definitely,
COVID but were on a ventilator or something.
no,
So
I
young
definitely
patients or
agree.
other
Yes, yes,
patients,
I definitely
it is
agree with you.
immaterial.
But if somebody who's having just COVID and he was quarantined for some time at home or in the hospital also, there were many patients who were just admitted into the hospital. But
No need for that.
as you are saying, as you properly said, if the patient had a gone on ventilator, then you further investigate the patient first. Right? You directly, even directly going for any investigation, I would say, if you ask the history of the patient, if you examine the patient, whether the patient has bilateral leg swelling, you will come to know patient whether the patient has a DVT or not. So there are many things. And yes, anti-pro-BNP, I even I do test it for certain patients, whom I feel that. So this is all the clinical decision making. You just don't do it because you have heard that the patient is having had a COVID, but you took the history. You came to know that patient was on ventilator, so you are suspecting that the patient must be having some problem. Then you advise this. And as I said, not only Covishield has caused many problems, myocarditis, and then these thrombotic events in many patients. And somehow I feel that every month or two we are coming to you are getting the news of somebody whom you knew and who was comparatively at a young age, and they are all of a sudden going. In just 2 days back, we have heard what Dr. Rajkumar had gone through. So somewhere this could be an impact of COVID also. Yes, I agree. Any more questions?
Do we have any more questions? Um, no, sir.
Anybody for the airway?
Dr. Manisha Ghosh had raised a hand. Manisha ma'am. So regarding the airway, there was one question in the chat box which stated that do we need to give a particular position or for video laryngoscopy, or the routine the same position is acceptable?
Do you want me to say that?
Yeah.
Yeah. So again, for video laryngoscopy, you don't need to specifically give any position because that's the advantage of video laryngoscopy, that you don't need to give a sniffing position. But we recommend to give a 20-degree head elevated position for all anesthetic, whether you're pre-oxygenating, or you could give more for pre-oxygenating. But even for video laryngoscopy, we continue with that position. So it's always at 20 degrees minimum, at 20-degree elevation for that position. And the benefit is that you don't need to do what you conventionally need to do for direct laryngoscopy.
Yes.
Not necessary, but again, I think every anesthesiologist has their technique, I think. So even when I try to tell some people, oh, why are you doing this? They will say, no, this is what suits me. So as long as it results in first pass intubation success, I think it's okay. It doesn't really matter.
One more doubt which I had personally, you were emphasizing about noting the time. So this time is what exact time are you talking about? Time of failing to complete ventilation failure or number of attempts? Because most of the time we are mainly concentrating on oxygenation, saturation, rather than keeping a track of the time at that
This is
situation.
all stemmed actually from the Ellen Bromley case, So the thing is that a lot of time had lapsed. It was like 1 hour, 1 hour, 45 minutes. You're so much in that mess, you don't realize kitna time ho gaya, So it is from the first time when you're in the crisis, when you're in a difficulty. with intubation, and then the downward spiral begins. The time is from there. So someone has to keep track that, look, it's 20 minutes and we haven't succeeded. Now it's time to call somebody.
Even though
Sometimes I
the
see,
saturation is maintained.
yeah. So, not the saturation, but from your onset of difficulty. Sometimes, I go into, I work, of course, in an institution, so I have some different challenges than what you have. I go into an operating room and I see 2 or 3 residents are doing all kinds of things to secure the airway. And, I asked the ward boy, how long has this been going on? So he says, 15 minutes chalu hota. Like, that's how long they were been doing it, but they haven't bothered to call some senior. I'm just saying that not deliberately, but sometimes you completely lose track of time.
Yes, I agree.
It is important for you to escalate.
Yeah.
You need to escalate. You need to think of somebody who will come in and think of solutions, or you need to have another plan. You can't just go on and on and on, in that. And that is why keeping track of time is as important as tracking your saturation.
All right, ma'am. So, Manisha, ma'am, you can ask your
Yeah,
question.
I had a question actually both for Sheila and Dr. Shilpa and Sheila ma'am. This is more like something from experience because we work alone and when we face difficult intubations we try to keep everything ready. But there's one thing that I do is like after giving the sedation and propofol, I try to do a very gentle laryngoscopy to get a idea of the view of what I'm going to see before the muscle relaxant, and that has helped a lot. Then I know, okay, this is an okay intubation. I will be able to manage. What do you think about this, madam? Is this recommended, not recommended, or is it just a practical jugaad that we are doing? Because
So,
this is not mentioned anywhere. A gentle
yeah.
laryngoscopy just to get a bird eye view
But
of
I'm
what
not
you may
hearing
see.
this first time from you, because I have 1 or 2 senior madams who've also been doing this. It
Yeah.
makes you feel more confident, definitely. If you
Yeah.
ask me scientifically, no benefit really, because how is
Okay.
it going to change anything? If you're going to get a difficult view, what you're going to do, right? And what happens is, your depth of anesthesia, and you're already kind of, again you intervene and again you have to deepen the plane of anesthesia. So sometimes it can be a bit counterproductive. So it really doesn't
Yeah.
serve the
Yeah.
purpose. Yeah, but again, when we are in the era where give the muscle relaxant, don't not give the muscle
Yeah.
relaxant, give relaxant, don't test, you don't waste time checking for muscle. You're giving lesser time, you're faster to intubation, than when we are checking with the mask ventilation. So we are in the era of where
So
we give the muscle relaxant. And I was alarmed when I went last time, I think it was to Thana, to see that every private practitioner is using Sugamadex. We are not at Tata Memorial Hospital using Sugamadex in each and every patient. We are very selective in the patients that we use. So I was amazed to see that, that's the level in the private practice. Everybody has switched over. So I think in that era, when you're using Vecuronium or Ocuronium and you have Sugamadex, I don't think it would be warranted, but it does make you feel definitely a little more
yeah,
confident.
so then one more thing that I do is like I also keep scoline and my atracurium, which I normally use for intubation, ready. And then if I think it's going to be difficult, please give scoline, otherwise give atra, and then we'll go ahead. That kind of thing. So that's because we work alone, and the staff that is surrounding us is not always the best. Every day they are in the OT as if it is their first time in the OT many a times. So these are the think of like self-defense mechanisms that we adopt to keep ourselves little comfortable.
Yeah, I agree with you. I use quite a bit of choline, even the intensive care unit, though there are a lot of contraindications. So I see the younger generation is very absolute no about choline. But one thing about choline is very rapid acting, but it does take time to come out of choline. Huh? It's
Come
not
up. Yeah.
fast
Yeah.
always. It can take 8 to 10 minutes
Definitely.
sometimes to come out of choline. So don't think that always giving choline is going to, kind of save you in that situation.
Right, absolutely. And just one more
So,
thing for Yatin, Dr. Yatin, if I
Yes.
may, before
Manisha,
I.
I
Yeah,
wanted to ask you, sorry
yeah,
to
yeah,
interrupt. So, when you're doing that check laryngoscopy,
yeah,
is the relaxation good? It's like, the intensivist
yeah.
intubating.
Yeah, see, I don't want such a good relaxation that I have to see right into the larynx, but little bird eye view of what I may be able to see. And I give a good depth of anesthesia. The propofol is very well given because we are doing endoscopies only with propofol. So I know laryngoscopy stimulus is much more than that would be for an endoscopy. But I think if you can do an endoscopy and maintain the patient for half an hour on propofol, definitely a very gentle laryngoscopy is allowed. Many times, even a nebulization with lignocaine I give. in such cases, so at least some part of the oral airway is anesthetized. See, this is all for me because I'm alone. If it is a really difficult intubation, then yes, we would call somebody right in the beginning and then not later, because in private practice people are not easily available.
You
Else,
never
we
had
don't.
gag reflex with this.
No, she gives the
Then
patient.
I stop.
I think I know
Yeah, I
exactly
keep
what you're
it
talking
easy
about, Manisha, because I had some senior madams who had this practice, would take the patient very deep. It gives you a bit of a confidence. But like
confidence. Yeah,
Shilpa is saying, if they're in lighter planes, they can go into laryngospasm. I mean, sometimes it can be counterproductive. But I
yeah.
think, a few things which I think
We are putting
really.
supraglottic devices only on propofol routinely, so it's manageable.
Yeah, just a few things I want to say that what I think can really, I am more nervous if I'm working alone. And yeah, really hats off to those of you who work alone because, I think, like things, I don't mind using a DL when I'm in an institute because there are 10 people around me to come and help me. But, the use of a VL, the use of a stillet, very underutilized, a stillet. And even those who use a stillet do not use it properly. People use a stillet. The purpose of a stillet is to pre-shape the tube. It is not to keep the same curvature. So, people, I was never taught how to use a stillet properly. So you put the stillet at the tip of the tube, but you need to pre-shape that tube. It has to be J-shaped or hockey stick shape. It has to deliver the tip anteriorly. So these things were never taught to us when we did anesthesia. So this is really important because I see people who come in, they will put the stillet in the tube. So it's not helping, it's not serving the purpose other than just stiffening the tube. It is not helping you live
Very,
your so
very
still, if use of a still, so if I was a private practitioner, the things I would really keep very close to me is I would keep a video laryngoscope. I would have a supraglottic airway device absolutely ready, especially if the mass ventilation is going to be difficult. I would use a stillet with every attempt at direct laryngoscopy, not as a rescue, during the first attempt. Because, unlike direct laryngoscopy, your tube is going in the same axis as your left side. When you're using video laryngoscopy, you have a nice CL1 view, but that is not the direction in which your tube is going. And often it is an anterior larynx. And if I'm alone, it's always better to go in with a stillet. And especially if you're using a D blade. The recommendation with a D blade or hyperangulated blade is always go in with a stillet. But I see people not using that. I would use an entry exchange catheter. In case I have a supraglottic airway device, I could ventilate and I need to intubate. And I don't have a bronchoscope immediately available. So these are a few things I would always keep in my kit. And I would keep a scalpel bougie too. How many of us really have that ready available if we are really in a crisis? You'll say, "Arey, surgeon hai," but the surgeon may not be the favorable surgeon. You may have a operation. He'll do a episiotomy very fast, but he won't be able to do a tracheostomy for you. So you have to also see when you see surgeon, who is the surgeon that is available with you. So I think some things, the things that you keep when you're alone, I think are really, really important. In case, so then you don't have to worry even if you fail or you don't do that check scopy or you have any difficulty, you can ventilate the patient.
Even Crook's bougie also is a good option.
Thank you.
Gillette, Crook's bougie, it has a good anterior curvature
Yeah,
and
anytime.
it is maintained with the stillet, big long stillet.
Yeah.
Many people don't have, even institution doesn't have it. Some of the places have
So,
made it.
between a stillet and a bougie, when you use it with a video laryngoscope, use a stillet.
Yeah,
Because
correct.
with a bougie, and many people must have seen this, use a video laryngoscope and a bougie. I'm talking about the classic bougie. I'm not talking, there are some special bougies that come where you can alter the tip. And you
The
use
Crook's bougie has the anterior curvature, proper anterior curvature.
yeah, so that's a special type of bougie. But if you use a bougie with a video laryngoscope, you get that excellent view, and it's frustrating. Your bougie is going into the esophagus, going into the esophagus. And it's absolutely the reason is this, because a stillet in the tube will help you deliver the tube anteriorly, whereas the bougie will not help you do that unless you use one of these other type of bougies. So, using a stillet with a video laryngoscope is really paramount.
I've used it many times, but long before because access to fiber optic bronchoscopy was difficult. So any patient who has very small mouth or no finger, no mouth opening, I used to put the Crook's bougie and just awakely and used to guide it try to guide it through the trachea. So that used to serve the purpose. But now with the advent of and easy access of fiber the actually flexible bronchoscope, not fiber optic, these are all fiberless. Yeah, so things have become much easier now.
Can I ask question to Dr. Shaila? What is the role of ultrasonography in difficult airway assessment?
Yeah, so if you hear sonographers give talks on difficult airway, you have a whole lecture on a whole gamut of things that you can do, right from confirming tube position to everything. But I think the real utility is, you identify the cricothyroid membrane, especially in a difficult airway. So we make our trainees in any difficult airway do the laryngeal handshake. So, we larynx is a rhomboid structure. We move it from side to side with the index finger going down and actually palpate the cricothyroid membrane. We do this routinely for every flexible bronchoscopy, and we make them palpate the cricothyroid membrane and instill the lignocaine. So they are very familiar with where because see, in your crisis, you say, do cricothyrotomy. But where is the cricothyroid membrane? I've never palpated. So this is all in theory. So if you're doing it every day, you're seeing, we do that. So Richard Levitan and this is all there in the IDA guidelines, has very beautifully, even in the DAS guidelines, described the laryngeal handshake, how you could feel this rhomboid structure, move it from side to side, palpate, with the index finger, we go down, all the way down like this, and we feel that dip where you feel the cricothyroid membrane. And so, this can also, now if a patient has a normal neck anatomy, lean, thin patient, it's fine. But someone who's very obese or someone who has neck nodes or, when the trachea is deviated or something like that, it's very, very helpful to do the ultrasound and to locate the cricothyroid membrane, even to mark it. And sometimes if it's really difficult and you're going all the way, giving a general anesthetic, even putting a needle in can be helpful. So I think this is one place, not only electively, but also in an emergency to identify the cricothyroid. This is where I feel the real utility is. And if you think, the patient, you've secured the airway, tube is in, but the patient is desaturating and you're worried there is a pneumothorax, then very quickly with the ultrasound, you can rule out, you can look at lung sliding and you can rule out that there's no pneumothorax because you don't have time to do an X-ray. So this is where I feel in emergent airway management, you can really use ultrasound. But, there are all kinds of things about people looking at tube position, people looking at predictors of difficult airway, but then they're all plus minus, nothing is like gold standard that is recommended for use except these, yeah.
Thanks.
Do we have any more questions?
Dr. Yatin, can I just go for a debate,
Yes, sir. Yes, sir.
I think now with the internet and advocates are very smart. See what you are talking about, American Society of Airlines, guidelines and everything. The advocates are very smart and they will pick up what you have not done. See, when you got a plaintiff and defendant, plaintiff is a person who is making a complaint. You may say that I have done the best possible. Now, I know a situation where patient was say grade 1 or 2, ECG was not done. And patient had some problem, and the only thing is patient was also some other problem. I don't know what was the technical problem. But very important, not doing ECG was labeled as a criminal negligence.
Sir, I would say.
So, now I will put it this way: only contraindication for not doing ECG is patient has no money. It's a non-invasive investigation. ECG, even common people, they want only 2-3 things. They may not know what basically, hematological investigation you go. ECG, XHS, blood count. So if the patient, because this advocate, the lobby, if you Google, they are becoming very smart. And now somebody has been put in trouble because he didn't do neuromuscular monitoring for ASA grade 1 patient for a spine surgery. So
Sir,
I
they must
think,
not, I would
yeah,
say, must not have had a good lawyer who has good knowledge about all these guidelines, I would say. I will still say, if the guidelines are saying this, it is still defensible. What court wants is whether you have assessed this patient well or not. Whether you have, there might be a possibility that the anesthesiologist might not have documented it well. He might not have graded the patient or written, or he must have graded, but he must not have written the patient that it is patient is grade 1. So everything, if the proper documentation is put, the and these nice guidelines as well as ASA guidelines are globally accepted. So even if the lawyers argue, it is defensible in the court of law. Only thing is that the lawyer should know, and the person who is being litigated should know about those guidelines.
May I just add something?
Yeah, please.
Here, I would say, even though we have the luxury at the Institute of performing all the investigations, we do not do X-ray chest and we do not do ECG for patients under the age of 40 unless they are symptomatic. And I really like Dr. Kairnad's emphasis on see the patient. But sometimes I speak to private practitioners, they say the first time I'm seeing him is when he's on table. So it can be a challenge. But what I'm saying is if the patient is not symptomatic, if the patient doesn't, then you are justified, routinely doing it in every patient may be an overkill. And I like the thing you talked about very much about, counseling the patient. A lot of people say, Sara investigation kar leta hu. They feel that they're safer and they're better. But if you try to tell them that, you might find something or you might, it's the way you tell them that, there's a downside of just over investigating yourself. Not just the cost, because people only think it's for the cost you're saying no. So I think that part is also very important, because we are investigating too much sometimes. You see a patient come, they have a whole file of all the investigations.
And
Uh,
sometimes even false positive can also make the patient more anxious and fear can increase.
So, and one more thing, you talked about the other side where the surgeon says, why do you want so many investigations, which I think also may be a concern. So I think here, especially in private practice, gaining the confidence of the surgeon is very important, especially with someone you're routinely working with. Because, when you have that one episode where you have really bailed the patient out, that's when they realize the value of the anesthetist and the value of what you're saying, optimizing. I'm sure you have been through that, that those surgeons forget very soon. But that's when they realize that you're not just saying it. So both for not investigating too much, but also for investigating further. When
Saying
the patient is symptomatic, you're
our
saying,
patient
"Kuch zaruri nahi hai, ye zaruri nahi hai, why do you need this? Why do you need that? Why are you delaying this thing further?" So I think, like Sir said, if you have a situation where the patient has poor effort tolerance, or even is young and has, has poor effort tolerance, you'd really wonder, and I would want to do an echo in that patient, even if it's 35 years old. So missing those symptoms and not acting on them, I think that would be negligence. I don't know.
And there are many criteria, ma'am, like Duke score, Med score. You can assess the functional status of the patient based on these all questionnaires, as well as there are tests. Depending on we will come to know whether the patient is is at risk of what or not. And yeah, that's thank you. Yeah, and the institutions are, I mean, not all, but I'm happy to know that many people, many
So we
institutions.
don't do it because we have to justify every investigation that we do. We cannot even do CBC in every patient going for surgery, because they really crack down on the investigations that we have to do. Not
I
because
would
we
say,
can't afford it, but because it's not indicated.
right, the cost is not the only factor, madam, because overall, as I say, that can increase delay in the surgery. If the surgery is sometimes, it is actually to be done immediately, and people delay it just because 2D echo is not getting done. Only just as 2 days back, this thing happened that today the cardiologist is not ready to come because he has some work. The other cardiologist had gone out of town, and patient is 80-year-old, and he wants to get, neck femur fracture get operated, and the surgeon is in the coop now what to do because no one is ready to come. So he called me up. I said I will give my management won't change if I give a regional block to the patient, lumbar plexus plus sciatic nerve block, but I will assist. So people, I would say anesthesiologists should have the focus now. Focus workshops are coming very routinely, so at least we can have an idea of what generally, the in emergency situations, it does help that if we ourselves do the 2D echo and just assess the at least the ejection fraction of the patient.
I am in a corporate hospital, so I think we do, after hearing this lecture, probably we over investigate the patient. But we, in fact, after 2 months, the surgeons only tell them, एक CBC करवा लो, 2 महीने पहले किया था. I don't know. So sometimes some surgeons are like, and we have to tell the patients, अरे नहीं, he says नहीं madam खून देके तो आ गया. So it is like that, they have shown the surgeon 2 months back and now they're coming for surgery and they come with the fresh investigations. But I do agree, I don't know, X-ray chest, we make it compulsory and ECG about 35 and CBC for everyone. And other SGOT-PT and electrolytes depends upon the patient.
Actually, in private practice, the patients are thoroughly over investigated before they come to us many a times. We are the last one in the sequence who actually sees the patient. Before that, they have come with 2D echo, everything. Now, two opposite situations. 30-year-old patient came with 2D echo. We said it was not necessary, but it was already done. Second situation, there was a 30-year-old lady. She had 2 children, normal deliveries. She came for lap cholecystectomy. She didn't have a 2D echo. I said, okay, no problem. She doesn't need one. The surgeon was also ready to operate, but the patient belonged to the physician who owned the hospital. He said, no, No doing without 2D echo. So we had to postpone the case to the next day after the 2D echo was done. So we have these situations and we have to deal with them as they come.
Here in India, the institutions are, as Shilpa madam was saying, that in our institute, people are like, this is routine, that routine investigations are done. So why institution? Because they are habitual.
Yatin,
It is a habit. One sec, Bhavesh bhai. It is an habit.
yeah,
Second thing, there is an, concern, medical legal concern. Many people feel that, as I said before, whole, like, if you have investigated thoroughly patient is fit for surgery. This thing we have to remove from our mind. The clinical judgment examination is more important than the routine investigation. Many patients who have, routine investigation, everything is normal, but if patient has some other, that can be picked up from the symptoms. As I said, that I explained that case. The people, the orthopedic surgeon saw the MRI and operated lumbar spine, but he had cervical prolapse dips, and after positioning was given, he developed paraplegia, and they were in scope. What they did, I mean, actually became the detrimental to the patient.
But I just comment, I think this is where guidelines help you because across the country, institution, in the same city within 10 kilometers, which investigations to do varies. So, when you have evidence-based guidelines, and that is something that will definitely,
Yes,
help you even in a court of law, even if you choose to underestimate, investigate.
yes.
Yatin, just a thought. The American ASA has given all these guidelines. If our Indian students go for a job or admission to the medical colleges there, a private college there, one of in the visa process is that please do an X-ray test. Correct? Especially for Indians.
That
They
is to
think that
rule out
Are you getting
Tuberculosis
me?
is very different,
See,
Yeah,
Bhavesh.
not only
tuberculosis.
that,
That is
So
because of
here,
routine.
when we are putting an ASA guidelines that हमको एक्सरे टेस्ट नहीं करने का, इमेजिन करो अमेरिका में जिसको एडमिशन लेने का है, जिसको काम करने का है, उनको कंपलसरी है एक्सरे टेस्ट करने के लिए, और हम उनके गाइडलाइंस में बोलता करके कि एक्सरे टेस्ट मत करो क्योंकि आप इसके मेडिकल के लिए जा रहे हो. It's on a lighter note I am talking that
But उसको
the
anesthesia में
results
देना
they are doing X-ray test for all the people coming from India or these poor
yes,
countries there because they know कि उनको कॉक्स हुआ रहेगा.
no.
Correct?
Apart from that, I went as an observer. I went
it's
as an
okay. They
observer
are
to.
just.
So they asked me to do titers, produce X-ray test.
Yeah, BCG. If you don't have a BCG or this one, they
Yeah.
will ask for the titers.
अभी देखो, there is a American consulate का lab है. There is if you want a visa, you have to go to that lab, and they get tons of investigation, and they get ISRA test also done. So that is, oh yeah, Dr. Bhavesh is saying is correct. See.
See, what I'll say, one thing here. In patients who have early pneumonia or pneumonitis, if you see a chest X-ray, it will be 110% normal. You will not find a single thing in there. But if you examine the patient, you will get findings. So just seeing the X-ray or just looking at the X-ray, it doesn't tell. I will still stress on one thing: the clinical assessment of the patient, preoperative evaluation tells us what to do and what not to do.
I just want to add one thing. We have to be very think to ourselves that why are we asking for this investigation? Is it to protect ourselves medico-legally, or is it to improve
For
the
patients,
functional status of the patient? So I like what Dr. Yatin said, because if I'm going to auscultate, I'm going to find something, I'm going to investigate further. I want this patient to be safe. So I'm not doing the investigation because I want to just protect myself medically. It's for the patient actually. If you ask me, we really have to think that why are we investigating further? Do we really want to know more? Why is a young patient having such a poor effort tolerance? If I do a echo and I see a low poor ejection fraction or poor, that will give me more information and that might save that patient and I might manage him differently. So I think the investigation should be more focused on patient management and safety rather than medical legal, kind of protection.
Yeah, so we are not doing it for medical legal. We are like, of course, the extra investigations are patient dependent, patient comorbidities, but the basic investigations are just like that. Means the dental surgeon, the one who comes for dental rehab, for last so many years, he has been telling us, तुमको क्यों चाहिए बच्चों का एक्सरे टेस्ट? बाहर किधर भी नहीं करते हैं, वाडिया में नहीं करते हैं. But we ask for X-ray test of a child.
Madam, we do operate, I do pediatric and neonatal surgeries, anesthesia for that. So there are many patients who are from the camp, and we are doing this service to those patients. So many times patients, like, the children just come, they, I do evaluate them after auscultating and everything, but they just, many times they just have a, CBC and urine routine microscopy. And it was many times I've said, told sir that, sir, if you find the child is completely healthy, you need not do even hemoglobin. As I said in my slide, most of the patients, you have to see, even if the investigations are normal, like, CBC made, if you see that the count is normal, everything is normal, and you see the patient's, the nose is full of, mucus, and patient is coughing, the, will those investigations tell us that patient is fit? No. So even if I don't do that, I can just examine the patient and decide whether this baby can undergo an operation right now or later. Many times the WC count
So
remains
some
normal.
of our surgeons will be really happy to know that. ओबीस पेशेंट है तो हम टूडीए को करते हैं, हमको पीएच चाहिए पेशेंट का, हमको एफर्ट पेशेंट चल नहीं पा रहा है तो हमको एफर्ट टॉलरेंस वी डोंट नो, so we are asking for टूडीए को, so our surgeons will be happy to know that.
Ma'am, even sometimes it is other way around. If
I
you
think,
want to
I
get
think
a 2D stress 2D done for particular patient, you are suspecting that patient must be having some CAD or something. Stress 2D echo, if you tell the cardiologist to do it, they are hesitant because they also don't want to take that risk, because while doing the stress 2D echo itself, patient can develop, the angina and deteriorate.
see,
So,
Dr. Nitin, excuse me for this. Now,
yes, sir.
you all are practicing in a hospital which are backed up by ICU and multi-speciality. Now, there are lots of our colleagues who are practicing in nursing home. Now, from nursing home, in case of complications, the patient, they get transferred to a medical college or to a tertiary care center. Now, what happens? When the tertiary care center, the patients are examined by the doctor who is on duty. He may ask for some advanced investigations, which the previous doctor has not done. And that keeps a small suspicious and, people, so slightly over investigation in nursing home may cost money or burden or may delay the surgery. But lots of things we would like to protect under umbrella, or when you are practicing as a solo anesthesiologist or a solo pilot, one should be very, very careful in assessing the patient. Yeah, pediatric cases, yeah, you go by the symptoms. Is a child has no cough, no symptoms. But lots of times we have got very rampant incidence of tuberculosis, diabetes. One has to be very, very careful, particularly when you are alone anesthetist and you are you are a guardian of the patient that particular moment.
Sir, I beg to
This is
differ, sir, in this. Even I have done a lot of cases in nursing homes, and now also I'm going to nursing homes, and still I would say we are doing, as Sheila Madam very well said it again, that we are doing it for patient safety, not for our safety. If we are seeing the patients clinically, and if you fail that this test has to be done, then it is justifiable, because you are checking, looking after the patient safety. But you just can't order the routine panel, because if you see something in that, and then patient might be, a high risk. It is the other way
But
around. Sir,
I would go optimize the optimum investigation must be
exactly,
done.
sir. If you find some,
Acha, now
if you
listen,
get
now
any
regarding,
finding from the symptoms and examination, then you investigate according to that symptom or investigation. If the patient is having breathlessness on and off, you will go for specific test. You will do the patient's med score, and you will investigate the patient further. If the patient is not having any symptom, and important is that whether that investigation is going to change your clinical your perioperative management. My only thing is that if that investigation is not going to change my perioperative management, I won't do that investigation, and it is completely justifiable in the court of law.
I would also add one thing. It's not always to change your perioperative management, but it's also for risk stratification. So,
Yeah.
it makes it easier to explain to the patient and their family that, look, this is what you have. So there is this additional risk. So I may not be able to optimize it prior to the surgery, but, they are aware that there is this risk. It kind of puts you also in a little safer place. So I
The nice criteria is based on those only. Any is ASA risk stratification. I mean, so we, it is more structured. I feel the criteria and more globally accepted.
Yeah, that was a good point, Dr. Sheila.
Yeah. And I want to say, because I have looked at the ISA guidelines, so we always think that something that is Indian is not good or it's a cut copy paste job. But actually, if you look at it, no, it's quite good for our needs and situation, because they've actually taken the best from ASA, from the NICE guidelines. It's a very reasonable job. And I think for people who just don't look at anything, it is worth at least looking at the ISA guidelines, because they have done it with thinking of the Indian anesthesiologists working in all kinds of settings and addressing our needs and situations. So, of course, looking at all the evidence, all these kind of guidelines that are available. So I think it's a very good job that they have done, and it'll definitely stop a lot of over investigation. That I can say for sure.
Any more questions?
No, sir, we don't
I
have
think
any.
it was a very well
Yeah.
questions. Excellent one, Yatin, Sheila, Shilpa.
Thank you.
Thank you.
Sheila was superb.
So,
I just felt like, keep on listening to her. It was really
same
good.
for both of you. Yeah.
It was good for both of.
Thank
I
you
mean,
for the kind invitation. Thank you.
I mean, anyways, I am going to give the vote of thanks. And the person who, I mean, being a secretary, and the person who is supposed to give vote of thanks is not there. So let me just give my heartfelt gratitude to our esteemed speakers for your, sharing of vast knowledge, experience, and sharing the situations, the real life scenarios, which will definitely help each and every one of us, in every day-to-day practice. So these guidelines, even if we keep on revising, people keep on forgetting things, and as both of you madam said, that when the time comes to do certain things, we sometimes gets like frozen, and we, even if we don't, you've done some, like you heard the lecture, and still you are not, that time, at that moment of time, you doesn't sometimes know. So just having the revision of these all things, and the upgrade, whatever upgradation which have happened with all these guidelines, and people now know which guidelines to follow. So AI guidelines, I mean, IDA
I done.
guidelines. Uh, so this table which you said, that now we have incorporated, which was not incorporated. So all these new, the knowledge has definitely going to help every delegate in their day-to-day practice. So my heartfelt gratitude to you both. And I also would like to thank our moderators for such an interactive session, and all the ISA team which has worked for this, behind the background work for this webinar, and making it successful. And I also would like to thank all the SAM's office bearer for joining and supporting us, and most importantly the delegates whose enthusiastic participation, and which made this session very interactive. And thank you all.
Thank you.
Yatin, just one
Right.
last comment.
Yes, madam, yes.
Yeah. No, not actually
I'm
comment.
so
It is a
I'm so happy to see na there are I mean the
yeah,
delegates are
still
still there, so they
there.
wants to listen to you all. I mean, so even I don't feel like you should
It is actually extended for more
Okay.
than an hour,
more
extra an
than
hour,
half.
and
I think we
still
can. I
we
think we
have
can stop
delegates
recording.
online.
I think.
And
Yeah, I think we can
definitely,
request.
Just
I think you can stop
Then
just
recording
one
now.
small request to Dr. Sheila and Shilpa, that whatever material they are asking us to read and all that, can they put it on the group so that we can share in our respective groups? They suggested some flow charts and some tables and
So,
all that.
I'll just
Yes,
let me just
Nilima.
share the QR code. If you just scan this, you'll get all the guidelines.
excellent.
Or you can
Okay.
just go to IJA, that is the November issue 2025. All are free download. So really useful content. I mean, I'm not saying read it because we put it together or because they're Indian, but really good content.
And Shilpa also suggested something. No? Shilpa, can you share that in the group so that we
Yes,
can?
yes, same. I just put it point wise. It's the same.
Okay.
But I'll
So
put
if
it
you
at
if
once.
you want, I can either share it with Bhavesh or Shilpa. I can share the articles and also the unanticipated missed esophageal intubation guideline. I think that's a really useful guideline. So
Yes.
I will share that with Bhavesh or Yatin or Shilpa.
yeah.
Thank you.
You are in the. You can share in the group, Dr. Sheila, in that webinar group.
Our 20th webinar.
Webinar group. Okay, I'll do that. All right. Thank you so much. Thank you.
Thank you.
Thank you so much.
Thank you.
Really
Thank you.
nice. Thank you.
Thank you.
I
Thank
once
you very
again
much.
thank
Congratulations.
speakers in an engaging session. And भावेश भाई बोल रहे थे आप कुछ? नहीं
Nothing,
सर
nothing.
बात करें सर. I guess
कुछ नहीं. Thank you very much. बहुत अच्छा हुआ. Congratulations everybody. Dr. Sheila madam, Dr. Yatin, Dr. Bhavesh, Manisha, both are doctor. Excellent. Very good discussion. Very interactive. The time which
So
बहुत अच्छा हुआ.
yesterday on the dry run, Sheila ma'am was actually asking a 2-hour webinar. Are there going to be delegates online?
Yeah, I was wondering because it's very difficult, but I must
I
commend.
mean, Dr. Bhavesh, अभी एक
more
मिनट
than
suggest कर
50
And
दो.
we
delegates
have
madam were
crossed.
still there.
Because you know, whenever I
Crossing our
speak about, they tell me 1 hour के ऊपर कुछ भी नहीं होना चाहिए to keep the attention of the people. But I see yours association is such an engaging, kind of delegates, and they're here for more than 2 hours. I'm
3
really
hours. 3 hours. 6:30. What is the time now?
It
Time
just
कितना हो
was
गया?
Yeah.
So the
English and the third
credit goes to the speakers, madam.
Exactly.
Yeah.
So they have seen who are the speakers, so they wanted to stay here till that long.
that includes you, Dr.
We
Kenna.
lost track of time, completely lost track of time. And so many things we have actually on a webinar base itself, before even we reading those stuff, we know what we are, the change of shift of the paradigm shift of the airline management, and what priority needs to be given compared to what we used to do earlier. So that helps a lot.
Thank you very much.
Thank you,
you.
ma'am. Privileged
you.
to have you here.
Thank you so much for the invitation.
Thank you, Shilpa
Really
ma'am.
enjoyed
Thank
it.
you.
Thank you.
Yes.
Thank you.
Bye.
Thank you.
Good night.
With this, now we conclude the session. Thank you.
Thank you. Thank
Bye.
you.
Good night.
Thank you. Yeah. Bye.
Bye.
Okay, Yatin sir.
Yeah. It
Thank
was
you, sir.
a great session, and thank you all for conducting.
I
this
think the
session.
takeaway point from your session is no investigation can replace clinical examination.
Examination.
That was the takeaway from your session.
Correct.
Long live
Okay, bye.
OSA.
Good night. Yeah.
Long live OSA.
Yes, sir. Long live ISA.
Yeah.
Thank you, sir.
Bye. Good night.
Bye. Good night, everybody.
Night.